vomiting since the last 2 months, beta, almost 8 weeks. He gives history of flatulence and foul smelling, bulky, greasy stools. RBS or the random blood sugar is 250 milligrams per deciliter, that there is hyperglycemia. CT abdomen reveals that image is not printed. CT abdomen will show you around the pancreas there is a big hypodense region. Hypodense means a blackish region, beta. That is nothing else but a cavity which contains fluid inside it. Okay? So definitely in the peripancreatic region there is a large collection of fluid that you are able to see. Which among the following is the next best step in the patient? What is the provisional diagnosis? What do you think? Or आगे? Yes. So please remember, beta, by the complaints which have been given, that is epigastric pain, fullness, nausea, and vomiting, beta. These are the symptoms basically due to a complication of chronic pancreatitis, and that complication is known as a pancreatic pseudocyst, beta. And we know that pseudocyst is a complication which can develop after both the both the types of pancreatitis. It can be a complication of acute as well as it can be a complication of chronic pancreatitis also. So here the patient may be a known case of chronic pancreatitis, and after which now the patient has developed a complication that is a pancreatic pseudocyst. Why there was a why would we say that it is a case of chronic pancreatitis itself? Yes, so we know acute pancreatitis agar hota, so the patient comes to the emergency beta with complaints of severe acute epigastric pain radiating to the back and severe nausea and vomiting beta. Okay, and that would start all of a sudden, not a prolonged history of almost 2 months. Okay, so यहाँ पे they have given a prolonged history, and second important, they have also said the patient is having main symptoms like flatulence and foul smelling bulky greasy stools. फाउल स्मेलिंग बल्कि ग्रीसी स्टूल इज नोन एज स्टेटोरिया बेटा. हमें पता है flatulence happens when the carbohydrate is not properly
मार तो
absorbed.
ये
That
बात
leads to
किसी
bloating and
पाहिजे
flatulence beta. Whereas steatorrhea happens when the fat
so
is
I
not
paid
properly digested or
again he
absorbed beta.
wanted to eat
So please remember,
then
flatulence
I
and
said
steatorrhea,
no
both
no
of
I'm
these
not
are
paying if
features
you
of
want you only
malabsorption.
pay yours
And we know
then
malabsorption
then
happens in patients
now
of
he took
chronic
phone he's
pancreatitis
like
beta when the
Yada, you
pancreatic
said you don't
enzymes
have
are
net
not
and
secreted
all
properly. Second
hotspot
important thing,
and he's
RBS
like no
levels.
no
We
just
know the
now I
RBS level
recharged
of the patient is 250. That is very high. That is suggestive of hyperglycemia or diabetes mellitus. We know in patients of chronic pancreatitis, as the pancreas are damaged, therefore
म्यूट
insulin
बन रही
secretion
है.
gets affected, leading to hyperglycemia or diabetes mellitus. So, जो second or third line है beta, these two lines which are there definitely they are telling you about a case of chronic pancreatitis. But the first line tells you that in a patient of chronic pancreatitis and from the last 2 months the patient is having features like epigastric pain, fullness, nausea, and vomiting. That can be due to a complication known as a pancreatic pseudocyst. Or हमें पता है that when pseudocyst develops, it compresses the stomach beta, and therefore the patient will have problems like fullness, nausea, and vomiting. ठीक है? Which among the following will be the next best step in the management? बोलो. Last option is Pastos pancreaticojejunostomy. Last option is a Pastos pancreaticojejunostomy. Bolo. What is the treatment for a pancreatic pseudocyst? Next best step है ना. So next best step में first you will treat a pancreatic pseudocyst and then you will go for a treatment of chronic pancreatitis. क्योंकि priority will be a pseudocyst and that is mainly causing the problems like pain, fullness, nausea, vomiting. So we know that for pancreatic pseudocyst beta, what we do, there is collection of fluid, so treatment has to be drainage. Now either it can be a either it can be an internal drainage or an external drainage. External drainage is done if it is going to external drainage is done if it is a infected cyst or a hemorrhagic cyst beta, and that is usually done with the help of a pigtail catheter. So pigtail catheter insertion and drainage will be done if it is an infected or a hemorrhagic cyst only. Otherwise, in all other types of pseudocysts, the treatment is an internal drainage, and that internal drainage is either open up the cyst into stomach called as cystogastrostomy, or open up the cyst into intestine called as cystoenterostomy. तो यहाँ पे cystoenterostomy की जगह क्या दिया हुआ है? Cystojejunostomy. It is one and the same thing. So cystojejunostomy is opening up the cyst into the jejunum and draining the cyst internally, beta. That has to be the treatment for a pancreatic pseudocyst. That has to be kept in mind. No issues with this. याद रखना है बात. And later on, definitely, once the pancreatic pseudocyst has been treated, then obviously you will treat the chronic pancreatitis of the patient. For that, you will give pancreatic enzyme supplementation. Second, insulin or oral hypoglycemic agents will be given. And third, whatever is the basic problem, okay, depending on that, you will choose either a drainage procedure or a resective procedure. Beta. We will talk about that chronic pancreatitis ka management in a while. Okay, so that is important. We know observation and follow-up can be done in a patient of a pancreatic pseudocyst, but in which condition? If the patient, we know that majority pancreatic pseudocysts, they do not require any kind of treatment. Beta. Why? Because majority pseudocysts are going to resolve spontaneously. अपने आप ठीक हो जाते हैं बेटा. But we know the rule of 6, right? If the cyst is more than 6 weeks old, if the size of cyst is more than 6 centimeters, or if the wall thickness is more than 6 millimeter, then it always needs a surgical intervention. बेटा ठीक है. तो अगर 6 cyst जो सूडो cyst है उसको 6 हफ्ते से ज्यादा हो रखे है, साइज 6 सेंटीमीटर से बड़ा है, या वॉल की थिकनेस 6 मिलीमीटर से बड़ी है, इन दीज 3 कंडीशन वी ऑलवेज हैव टू गो फॉर अ ड्रेनेज प्रोसीजर बेटा. एंड यहाँ पे as it has been more than 2 months basically for the pancreatic pseudocyst beta, we have to go for a surgical intervention, and that has to be cystojejunostomy. Agar they would have said that the patient is presenting to you within 2 weeks with the like from the last 2 weeks with these symptoms, then we would have gone for observation and follow up. We would have waited for some time so that the pancreatic pseudocyst automatically resolves. Okay. Chalo. Next important, if they ask you that pancreas mein which is the most common congenital anomaly? So we know the most common congenital anomaly of pancreas is going to be a pancreas divisum. हमें पता है that pancreas is usually formed by ventral bud and a dorsal bud. But when the ventral and the dorsal pancreatic bud will not fuse with each other, beta, that condition is known as pancreas divisum. और हमें पता है that pancreas divisum में the pancreatic secretions are not able to drain properly, and due to that the patient will have a high risk of pancreatitis. That is what is important to be remembered. Treatment is nothing else but ERCP with sphincterotomy. क्यों? क्योंकि यहाँ पे the opening of the pancreatic duct is very narrow. So you just have to widen up the opening beta, and that will be done by a procedure known as ERCP with sphincterotomy. Next, here we have a patient beta which states a male patient presents to the emergency room with sudden onset severe acute epigastric pain beta, and this epigastric pain is radiating to the back. The pain worsens when the patient is lying supine beta, whereas the pain gets relieved on bending forwards along with nausea and vomiting. What is the likely diagnosis? So we know beta when a patient complains of a sudden onset severe acute epigastric pain which radiates to the back, it is a classical diagnosis of acute pancreatitis. Anybody, chest pain radiating to the back or the interscapular area is a feature of aortic dissection. Either MI or aortic dissection mein beta, the patient will have a chest pain radiating to the back. That is important to be remembered. So acute pancreatitis mein epigastric pain radiates to the back. इतना याद रखना है. Important is we know pancreas is a retroperitoneal organ. इसीलिए whenever the patient lies supine beta, all the abdominal organs compress the pancreas, causing worsening of pain. But whenever the patient sits bending forward, there is no pressure over the pancreas, or there is no compression of the pancreas, and therefore there is pain relief. Beta. Acute pancreatitis के cases में, please tell me what is the most common cause? The most common cause of acute pancreatitis is gallstones, beta, followed by the second most common cause is alcohol. तो याद रखना, most common cause of acute pancreatitis is gallstones followed by alcohol. Most common cause of acute pancreatitis in children is, yes. So please remember, beta, that the most common cause of acute pancreatitis in children is basically a blunt abdominal trauma, and that blunt abdominal trauma is especially due to the bicycle handle injuries, beta. The bicycle handle injuries in the epigastrium or in the abdomen are known to cause acute pancreatitis in children, beta. That is important to be remembered. Which surgical procedure is known to cause acute pancreatitis? ERCP beta. ERCP is known to cause acute pancreatitis, whereas which anti-diabetic drugs are known to cause pancreatitis? All the GLP analogs beta. GLP analogs which end with tide. Drugs like semaglutide, liraglutide, they are known to increase the risk of pancreatitis in the patient. Or even the antiretroviral drugs used for HIV, NAVIR drugs, they will also increase risk. Now, in a patient of acute pancreatitis, beta, what is going to be the radiological investigation of choice? Yes, so we know for all the retroperitoneal organs, the best radiological investigation is always CCT abdo beta. So investigation of choice radiologically in patients of acute pancreatitis is CCT abdo बच्चे. But याद रखना ये बात that CCT abdomen is done early or late in acute pancreatitis. Late. It is usually done after 72 hours beta because CCT abdomen is not used for the diagnosis of acute pancreatitis. Okay, it is just used to know the amount of necrosis which has happened. So what is the best investigation बच्चे to diagnose a case of acute pancreatitis? So please remember the best investigation is going to be serum lipase followed by serum amylase. We have to check for the pancreatic enzyme levels beta. And we know in patients of acute pancreatitis, the enzyme levels are going to be grossly elevated with almost 20 folds or 100 folds. So serum lipase is going to be the single best answer because it is more specific as compared to serum amylase beta. Clear? That will be used for diagnosis. Now, some patients of acute pancreatitis will come to us with complaints of bowel obstruction. Reason being, acute pancreatitis is known to cause paralytic ileus beta. And as the patient will have paralytic ileus, therefore, when we do a X-ray abdomen, this kind of a picture can be seen. What is this? Very good. Here you are able to see beta that the colonic loop is definitely not continuous because of that air fluid level, and this is classically known as the colon cutoff sign. So colon cutoff sign or sentinel loop sign on X-ray abdomen is a very classical feature in patients of acute pancreatitis. Sometimes the patient will not only have acute pancreatitis but rather acute hemorrhagic pancreatitis. That is, bleeding will happen from the inflamed pancreas beta and the patient will develop hemoperitoneum. Due to hemoperitoneum, as you are able to see, this is the blood beta. The whitish collection around the pancreas is nothing else but the blood. So it is a case of acute hemorrhagic pancreatitis, which in those patients, patient develops hemoperitoneum, and due to that, these are the two clinical signs which will be visible. First, important is bruising around umbilicus is known as Cullen sign. हमें पता है when there is bruising around the umbilicus beta, that is classically known as the Cullen sign. ठीक है? Whereas if there is bruising in flanks, that is known as Gray Turner sign beta. Bruising in the flanks is classically known as the Gray Turner sign. Please tell me, this will be a common differential for which obstetric emergency? It is a common or a close differential diagnosis for a ruptured ectopic pregnancy. Why? Because in ruptured ectopic also the patient will develop hemoperitoneum, and these two classical signs are clear. That is what is important to be remembered. Now, in cases of acute pancreatitis, when you have to know or when you have to assess the severity of acute pancreatitis beta, matlab, you have to check whether it is a case of mild, moderate or severe pancreatitis. The criteria that we use is known as, so the best score that we use beta is known as the Ranson score. There are multiple other scores that you can use, like the Bishop score is also one of them. So Ranson score and Bishop score are the two common scores beta that we tend to use to assess the severity of pancreatitis beta. That is what is more important to be remembered. Okay? Once you have diagnosed it as a case of acute pancreatitis, bache, the management is surgical or conservative. The management in patients of acute pancreatitis is always a conservative management. That is the same things. NPO, IV fluids, IV antibiotics, and analgesics to be given. Important, in the initial 48 hours of acute pancreatitis, the mode of nutrition should be enteral or parenteral. Parenteral. In the initial 48 hours of acute pancreatitis, always keep the patient on IV fluids, that is parenteral nutrition beta. Okay, because in the initial 48 hours, if you give enteral nutrition, there will be more secretion of pancreatic enzymes, which can cause more damage to the pancreas. But after the 48 hours, we will try to shift back or get back our patient on enteral nutrition as early as possible. Via which route? Oral route or the tube feeding? Usually tube feeding beta. Nasogastric or nasojejunal? Nasojejunal. Reason beta, when pancreas are inflamed, basically the head of pancreas will be edematous, which can compress the gastric outlet beta, and therefore there will be difficulty in gastric emptying. इसीलिए better go for a longer tube which directly delivers the food into jejunum. That is a nasojejunal tube. That is important. Understood? Chalo. So that is about the acute pancreatitis case. Next important, if I talk about carcinoma pancreas. Carcinoma pancreas is squamous or adeno? We know that carcinoma pancreas will always be an adenocarcinoma because it is a gland beta. And the most common type of carcinoma pancreas is basically a ductal adenocarcinoma. And this ductal adenocarcinoma is mainly seen in which part of the pancreas? Head, body, or tail? The head of pancreas is the most common site for a ductal adenocarcinoma to develop beta. That is what is important to be remembered. Now, if they say in patients of a carcinoma pancreas, what is the gene mutation associated? So, important gene mutation which is seen beta in patients of carcinoma pancreas is going to be the KRAS gene mutation. The others one will be the SPINK or the PRSS1. Okay? So please remember, KRAS is the main gene mutation that you have to remember. Other ones will be SPINK or the PRSS gene mutation as well. Tumor marker. What is the tumor marker for pancreatic cancer? So the tumor marker for pancreatic cancer is going to be CA19-9 beta. We know for colorectal cancer it is CEA. For colorectal cancer, it is CEA, that is carcinoembryonic antigen. But for pancreatic cancer, it is CA19-9 beta. That is important. If they ask you in patients of pancreatic cancer, again the same features will be there, beta. Okay, here in patients of pancreatic cancer, investigation of choice will be all retroperitoneal organs. The best investigation is always a CCT abdo. We know we cannot take a biopsy, beta, usually for pancreatic cancer, renal cancer, or the gallbladder cancer, or even for liver cancer for that matter. So usually we tend to go for a CCT abdo. Only a condition of pancreatic cancer जहाँ पे ERCP with biopsy is possible is पेरीएम्पुलरी कैंसर. ओनली पेरीएम्पुलरी कैंसर जो एम्पुला ऑफ वैटर के 2 सेंटीमीटर रेंज में होता है उसी के लिए बायोप्सी पॉसिबल है. अदरवाइज इट इज ऑलवेज अ CCT abdo itself. That is important. ठीक है. Now important is beta if the cancer is usually found inside the okay, if the cancer is usually found inside the head of pancreas beta, this is the classical appearance that is seen. What is this called as? It is the E sign, reverse 3 sign, or the Frostberg sign. So on the barium meal follow through, you are able to see the E sign or the Frostberg sign beta. That is what is important to be remembered. Now, whenever the cancer will be found inside the head of pancreas beta or in the periampullary region, what is the treatment? Very good. So please remember, whenever the cancer is found in the head of pancreas or in the periampullary region beta, please remember the patient is going to have what? Whipple surgery beta. The head of pancreas में या periampullary region में whenever there is a cancer, go for a Whipple surgery. The image that is shown besides beta, that is a classical picture of a Whipple surgery. Now what we remove in Whipple surgery? We remove the gallbladder, cystic duct, common bile duct, the duodenum, head, as well as the neck of pancreas beta. All these structures are removed in a patient of a Whipple surgery. And what are the 3 anastomosis that we perform? It is pancreatico-jejunostomy, hepatico-jejunostomy, and gastro-jejunostomy. These are the 3 anastomosis that we perform after a Whipple's surgery beta. That is important to be remembered. Now, if they ask you definitely in patients of Whipple surgery beta, what is actually going to be, sorry, the most common complication? Very good. The most common complication beta after a Whipple surgery, answer will be a impaired gastric emptying. Matlab the food is not able to properly drain from stomach into the duodenum beta. That is called as a impaired gastric emptying. That is the most common complication after a Whipple surgery beta. Do remember this. Next important, if I talk about if the cancer is in the body or the tail of pancreas, the treatment is डिस्टल पैनक्रियाटेक्टमी. उतना हिस्सा हटा दो बेटा. ठीक है. If the cancer is in the body or the tail of pancreas, go for a distal pancreatectomy. That is important to be remembered. Clear? Chalo. Next important, and that is the last part of pancreas, that is chronic pancreatitis beta. If I talk about chronic pancreatitis, please remember what is the most common cause of chronic pancreatitis? Yes, the most common cause of chronic pancreatitis is going to be alcohol, but alcohol is the leading cause. Second important, if I talk about what is the etiological classification of chronic pancreatitis known as? So the etiological classification of chronic pancreatitis is classically known as the TIGAR O classification beta. When I say TIGAR O, T stands for toxins. I stands for idiopathic. G stands for genetics. A stands for autoimmune. R stands for recurrent. And O stands for obstructive. These are the various causes for a chronic pancreatitis, beta. That is what is important to remember, to be remembered. Now, whenever there is chronic pancreatitis, हमें पता है, in cases of chronic inflammation, beta, the inflammation and the fibrosis will occur together. And due to that, the pancreatic tissue will get damaged. As the pancreatic tissue is damaged, beta, both the functions of the pancreas will get affected, exocrine as well as endocrine function. Exocrine function is secretion of pancreatic enzymes, and as there is exocrine dysfunction, there is deficiency of pancreatic enzymes, and that is known to cause carbohydrate or fat malabsorption, beta. Okay, that I've told you, flatulence or steatorrhea will be there. Next, endocrine insufficiency or endocrine dysfunction mein, there is deficiency of insulin, and due to deficiency of insulin, patient will develop diabetes mellitus, beta. Clear hai baat? Along with that, the patient will have a constant abdominal pain, beta, for a very long duration of time, because it is a case of chronic pancreatitis now. Important, if they ask you what is going to be the investigation of choice, see, if the problem is inside the pancreatic tissue, then you may go for CCT abdo, beta. But if the problem is inside the pancreatic duct, then the investigation of choice is MRCP, beta. So if it is in the tissue, then go for CCT abdo. But if the problem is in the main pancreatic duct, the investigation of choice will be MRCP, magnetic resonance cholangiopancreatography. And on that, which classical appearance you will be able to see? As the main pancreatic duct will get dilated in chronic pancreatitis, you are able to see a very classical chain of lakes appearance, beta. Okay. Second, due to stasis of secretion on the CCT abdomen, you are able to see stones inside the main pancreatic duct as well, beta. Now, if they ask you treatment, तो हमें पता है that the treatment in patients of chronic pancreatitis depends upon whether it is a problem in the duct or it is a problem in the pancreatic tissue, beta. Agar the problem is inside the duct, then you will go for drainage or resective procedure. If the problem is inside the pancreatic duct, bache, then we will go for drainage procedures. Ab drainage procedures are of two types depending on the extent of dilatation. If the pancreatic duct is less than 6 mm dilated, then we will just widen up the pancreatic duct opening so that the secretions are able to properly drain, beta. Okay, and what is that procedure called as? ERCP with sphincterotomy. तो हमें पता है when we do a ERCP and sphincterotomy, we widen up the pancreatic duct opening, beta, so that the secretions drain properly and there is no problem. But if the duct is even more than 6 mm dilated, beta, तो यहाँ पे duct ज़्यादा dilate हो चुकी है. तो when the duct is more than 6 mm dilated, then we directly go for a drainage procedure where we connect the main pancreatic duct directly with the jejunum, beta. Either it will be a end-to-end pancreaticojejunostomy or it will be a side-to-side pancreaticojejunostomy. The end-to-end pancreaticojejunostomy is called as dual surgery, beta. The end-to-end pancreaticojejunostomy is known as dual surgery, and the side-to-side is known as Pasto surgery, beta. The side-to-side pancreaticojejunostomy is classically known as a Pasto surgery. That was about the problem inside the duct, beta. But if the patient is having problem inside the pancreatic tissue, then we have to remove that fibrosed pancreatic tissue, and that is called as resective procedures. So whenever the pancreatic tissue has undergone fibrosis, then we have to go for resective procedures, beta. And resective procedures mein, if we have to remove the pancreatic head, that is known as Bejer's surgery, beta. So Bejer's surgery is definitely for the head of pancreas. So when you remove the head of pancreas, beta, that is classically known as the Bejer's surgery. And when we remove the tail of pancreas, that is a distal pancreatectomy. ठीक है, तो जब भी तुम tail निकालोगे, that is called as a distal pancreatectomy, beta. This is the treatment that we do in cases of chronic pancreatitis. So that was all about your chronic pancreatitis and pancreas, beta. Now let's talk about the next question. Here they say we have an elderly diabetic patient who presents to the emergency room with complaints of fever along with right upper quadrant pain and discomfort. General physical examination shows icterus, beta, that is jaundice. Palpation reveals the patient is having a tender hepatomegaly, that is liver has been enlarged and the patient is having slight pain. CT abdomen has been given below, and they say that the blood culture was done and it comes out to be positive, beta. They are saying that the blood culture was done and the blood culture has come out to be positive. ठीक है. Now they're asking you that what is the most appropriate treatment option in the patient. बोलो. A, B, C, D. A, B, C, D. How many with A? How many with B? C, D और बाकी लोग? ऐसे काम नहीं चलता. ठीक है. तो प्लीज रिमेंबर द डायग्नोसिस ऑफ दिस केस इज व्हाट? Pyogenic liver abscess. And pyogenic liver abscess mein answer has to be option D. That is IV antibiotics along with a pigtail catheter insertion and drainage. That is important to be remembered. Why pyogenic liver abscess? भाड़ में जा सब चीजें एक ही चीज. कौन सा अमीबा ब्लड कल्चर पॉजिटिव देता है तुम्हें? कौन सा एकिनोकॉकस ग्रैनुलोसस तुम्हें ब्लड कल्चर पॉजिटिव देता है? ब्लड कल्चर इज ओनली पॉजिटिव इन बैक्टीरियल इन्फेक्शंस एंड देयरफॉर इट इज अ केस ऑफ अ पायोजेनिक लिवर एब्सेस. क्लियर? So here it is a case of pyogenic liver abscess, and we know pyogenic liver abscess is a bacterial infection which is polymicrobial caused by multiple bacteria, and it is commonly seen in immunocompromised patients. Immunocompromised patients, here they have given an immunocompromised patient who is elderly, diabetic. Agar amoebic liver abscess dena hota to they would have more commonly mentioned a history of a chronic alcoholic male. That is more common. Okay. And here you are able to see there are multiple collections or multiple cavities containing pus inside the liver. And we know whenever there is a hepatic abscess or a liver abscess, patient will have jaundice, patient will have fever, patient will have right upper quadrant pain. All of these will be the common features, beta. ठीक है. अब इसमें ऑप्शन सी क्यों नहीं? सी में अल्ट्रासाउंड गाइडेड ड्रेनेज इज देयर. ओके, दैट वुड बी डन, बट along with that we have to also give antibiotics ना. तो प्लीज रिमेंबर therefore ऑप्शन डी इज अ बेटर आंसर जिसमें एंटीबायोटिक्स भी है और ड्रेनेज भी है. ठीक है. So that is what is important. Option B, it is metronidazole and diloxanide furoate. It is the treatment of choice for amoebic liver abscess. This is not a case of amoebic liver abscess. वरना blood culture positive आता ही नहीं. Clear? And option A says percutaneous aspiration and injection of scolicidal agents. Which therapy? It is classically known as the pair therapy, beta. So pair therapy जो होता है, it is the treatment of choice for hydatid cyst that is caused by Echinococcus granulosus. Over there also, as it is a tapeworm infection, the blood culture will never come out to be positive. Clear hai baat? So that is important. Now, if I talk about liver, definitely beta, the two main abscesses in the liver, one is pyogenic liver abscess, second is a amoebic liver abscess. Now we know that pyogenic liver abscess is polymicrobial caused by multiple bacteria together. But still, if they ask you which is the most common cause overall worldwide, most common cause worldwide, if they ask you, beta, answer has to be E. coli. The most common cause of pyogenic liver abscess worldwide is E. coli. In Asia, if they ask you, then the answer is Klebsiella, beta. The most common cause of pyogenic liver abscess in Asia, it is Klebsiella. Amoebic liver abscess, by the name, it is evident. It is mainly caused by an amoebic liver abscess. It is mainly caused by an organism known as Entamoeba histolytica. Most common site, important is pyogenic liver abscess. We know it is seen in immunocompromised patient, but it is not specific to a common site. Matlab, it can occur in right as well as left lobe of the liver, beta. Okay, but amoebic liver abscess, it is usually seen in chronic alcoholic patients, beta, especially males who are having intestinal amoebiasis. And from there, now the patient develops amoebic liver abscess. Here, it is more commonly seen in which lobe of the liver? Right lobe of the liver, beta. In which quadrant? Postero-superior quadrant. याद रखना, amoebic liver abscess is more common in the right lobe and in the postero-superior part of the liver. That has to be kept in mind. अब अगर क्लिनिकल फीचर्स की मैं बात करता हूं तो प्लीज रिमेंबर द क्लिनिकल फीचर्स फॉर लिवर एब्सेस आर गोइंग टू बी कॉमन फीचर्स विल बी देयर. फर्स्ट ऑफ ऑल, patient is going to have fever because both of them are infections, beta. Second, both the conditions mein liver is damaged, so both the patients are going to develop jaundice, which है. Next, in both the condition, as there is an infection, patient will have a pain abdomen, especially in the right hypochondrium or the right upper quadrant as well. And last, as both of them are liver abscess, there can be enlargement of liver known as hepatomegaly. Hopefully understood. याद रखना है बात. Now, if they ask you, definitely the symptoms are more severe in which condition? So we know the symptoms are more severe or the patient appears more toxic in pyogenic liver abscess. The symptoms are mild beta usually in a amoebic liver abscess. That is what is the difference. Investigation of choice. अब इतना तो पता है कि radiological investigation of choice for both the conditions will be same and the same logic follows. For children, the investigation of choice will be ultrasound abdomen, and for adults, the investigation of choice will be CECT abdomen. But here I'm asking you about the overall investigation of choice or overall best investigation to confirm the diagnosis. Why? Because ultrasound हो या CCT हो, उसपे तो इतना ही दिखेगा कि there are multiple cavities containing pus inside them. बस I will not get to know whether it is pyogenic or amoebic. तो अगर मुझे वो confirm करना है, what is the investigation of choice for pyogenic liver abscess? So please remember, for pyogenic liver abscess, beta, the investigation of choice overall is a culture. That is blood culture and pus culture, beta. ठीक है, तो blood and pus culture is the investigation of choice for pyogenic liver abscess overall. Whereas अगर मैं amoebic liver abscess की बात करता हूँ, amoebic liver abscess में definitely if they ask you that what is the investigation of choice, मुझे बताओ amoebic liver abscess में will the culture come out to be positive? No. So in those conditions definitely beta we have to go for serology, that is either ELISA or immunoblot. In those conditions beta we should go for an ELISA or an immunoblot. Now अगर वो ट्रीटमेंट की बात करते हैं तो हमें पता है that pyogenic liver abscess is a bacterial infection, so treatment has to be IV antibiotics, broad spectrum ones, and later on we have to go for early aspiration or drainage of the pus beta. तो याद रखना, in cases of pyogenic liver abscess the treatment is IV antibiotics and early aspiration or drainage with the help of pigtail catheter. But in cases of amoebic liver abscess we have to start with the anti-amoebic drug, the drug of choices. So here you have to start the treatment beta with metronidazole. And after starting with metronidazole, then you have to monitor the patient. If the patient's condition is going to improve, you will continue with metronidazole beta. Okay. But if the patient's condition worsens, then we have to go for aspiration or drainage. ठीक है, तो याद रखना metronidazole has to be given. If the patient's condition improves, then we will continue metro. Along with that, we will add diloxanide furoate. But अगर patient की condition ठीक नहीं होती है, तो then we have to continue metronidazole, but go for an early aspiration then. That is what is the treatment. When we aspirate the pus from an amoebic liver abscess, this is the classical pus which is seen. What is that? तो यहाँ पे you are able to see this is a classical anchovy sauce pus, also known as a chocolate pus. And anchovy sauce pus or chocolate pus is a classical feature of amoebic liver abscess beta. That is what is important. Whereas in cases of intestinal amoebiasis, patient is going to have a very classical ulcers called as, तो याद रखना, in case of amoebic intestinal amoebiasis, the classical ulcers seen are known as the flask-shaped ulcers. This has been a previous year image-based question, so do be aware of that. Flask-shaped ulcers are seen in intestinal amoebiasis beta. Understood. Now let's talk about another infection of the liver beta, and that infection is nothing else but hydatid cyst. Now, if I talk about hydatid cyst, it is basically an infection due to a tapeworm. What it is known as Echinococcus granulosus. Okay, Echinococcus granulosus is the main organism responsible for causing hydatid cyst beta. And if there are multiple hydatid cysts, then the causative agent is going to be Echinococcus multilocularis. तो याद रखना, अगर सिंगल cyst है तो आंसर इट एज Echinococcus granulosus, बट अगर मल्टीपल cyst है तो प्लीज आंसर इट एज Echinococcus multilocularis. तो याद रखना, malignant hydatid is basically caused by Echinococcus multilocularis. Malignant matlab not cancerous, multiple. Now important is if I talk about beta, which is the most common organ infected with hydatid cyst. The most common organ having hydatid cyst is the liver, followed by the lungs beta. So liver followed by lungs is going to be the most common organ involved. Here also the same features will be seen, like abdominal pain or pain in right hypochondrium, along with hepatomegaly, fever, and jaundice. Important to be remembered is that which is going to be the investigation of choice. Same radiological investigations will remain same beta, that is CECT, abdo, and ultrasound for children. But overall investigation or best investigation has to be serology again, beta. And serology mein either we can go for ELISA or a immunoblot again. Reason हमें पता है Echinococcus granulosus is a tapeworm. So again it cannot culture beta. Therefore you have to either go for an ELISA or you have to go for an immunoblot. That is the investigation of choice or best investigation overall which will confirm the diagnosis. अगर वो बोलेंगे बेटा in case if I have done a CECT abdo, this is the classical appearance which is seen. जहां पे क्या दिख रहा है the endocyst is floating beta inside the fluid collection, and this is going to give you a very classical sign known as the floating water lily sign. You are able to see the very classical floating water lily sign beta. Which classification is used for hydrated cyst? The previous classification was called as the Gherbe's classification. So Gherbe's classification is used for hydrated cyst beta. Nowadays we have started using the WHO classification. According to Gherbe's classification, floating water lily sign will be which type? Very good. According to Gherbe's classification beta, agar water lily sign दिखता है, तो it will be classified as Gherbe's type 2 beta. Hopefully clear to all of you now. And WHO type 3. Important is अगर वो treatment के बारे में पूछेंगे definitely बेटा, if they ask you about the treatment, so please remember the treatment is going to be which therapy? So in cases of hydrated cyst or echinococcus infection beta, the first line management is always and always the pair therapy beta. What is pair therapy? Percutaneous aspiration, injection of scolicidal agent and reaspiration. मतलब पहले एस्पिरेट करो जितना भी फ्लूइड कलेक्टेड है, फिर उसके बाद इंजेक्ट स्कोलिसाइडल एजेंट्स बेटा, एंड आफ्टर वेटिंग फॉर 20 मिनट्स रीएस्पिरेट दो स्कोलिसाइडल एजेंट्स बैक. That is known as pair therapy. But along with pair therapy, we have to give a drug of choice as well, and that is albendazole. So pair therapy and albendazole is the treatment of choice in patients who are suffering from hydrated cyst beta. कोई दिक्कत? So that is important. In case pair therapy contraindicated hoti hai beta, so we have to do a surgical removal of the cyst, that is called as cystopericystectomy, that is known as cystopericystectomy. Now if I talk about some one-liners from liver tumor, which is the most common malignancy of liver? The most common malignancy in liver, answer has to be metastasis beta. Metastasis means primary or secondary malignancy. तो हमें पता है that most common liver malignancy will be metastasis or secondaries beta. Why? Because all the GIT cancer commonly metastasize to the liver only. Therefore, if they ask you which is the most common primary malignancy, primary का मतलब which starts from the liver itself beta, and that is going to be HCC, that is hepatocellular carcinoma beta. और हमें पता है hepatocellular carcinoma is also known as hepatoma as well. Important, hepatocellular carcinoma is associated with which adulteration disorder? Aflatoxicosis. Aflatoxicosis is commonly associated with HCC beta. Which dye exposure is basically associated with HCC? Dye. Thorotrust. Very good. Thorotrust dye is the one beta that is commonly associated with hepatocellular carcinoma. That is important. If they ask you about the most common primary tumor in children, the most common primary liver tumor in children अगर पूछा जाए तो answer has to be hepatoblastoma. The most common primary liver tumor in children, answer is hepatoblastoma. And last, most common benign liver tumor overall, hemangioma. The most common benign liver tumor agar pucha jaye, most common benign liver tumor, if they ask you, answer is a hemangioma, which arises from the blood vessels beta, followed by FNH, that is focal nodular hyperplasia. ठीक है, तो मोस्ट कॉमन बेनाइन लिवर ट्यूमर, आंसर इज हेमांजियोमा फॉलोड बाय अ फोकल नोडुलर हाइपरप्लेसिया. मुझे बताओ, the primary malignancy of liver known as hepatocellular carcinoma is more common in males or females? So it is going to be more common in males because it is associated with alcohol, mainly alcoholic cirrhosis, whereas the all benign liver tumors are more commonly associated with females beta. All the benign liver tumors will be more commonly seen in females. Reason, all the benign liver tumors are commonly associated with the OCP intake, that is oral contraceptive pill intake, will increase the risk of all the benign liver tumors. That is what is important to be remembered. Clear है बात? चलो. Next important if I talk about is nothing else but the gallbladder beta. If I talk about gallbladder now, so please remember the first condition we have to talk about is gallstones. Gallstones is also known as Gallstones is also known as a cholelithiasis or a calculus cholecystopathy beta. Important. There are three types of gallstones that we have. The first one is cholesterol gallstones. Second one are the pigmented gallstones, and the third one are mixed gallstone. Which are the most common gallstones overall? The most common type of gallstones overall will be the mixed gallstone. Which are the most common gallstones in Asian patients? So we know the most common type of gallstones in Asian individuals will be the pigmented gallstone. And which is the classical gallstone seen in fat, fertile female in her 40s beta. So fat, fertile female in her 40s, if they ask you, the most common type of gallstones will be the cholesterol gallstones. That is what is important to be remembered. No issues with this. Now, majority cases of cholelithiasis or gallstones will be symptomatic or asymptomatic. Majority cases are usually asymptomatic beta. तो majority cases में gallstones are an incidental diagnosis बच्चे. But in case if the patient is having any complaint, most common complaint will be pain abdomen. And please tell me, in patients of gallstone, the abdominal pain is going to worsen after food intake, especially which kind of food intake? Fatty food. So after taking fatty meals, beta, the patient's abdominal pain is going to worsen because for fatty meal digestion, we need bile. That is the reason definitely the pain worsens after a fatty meal. Now, investigation of choice will be a CT or an ultrasound. तो याद रखना the investigation of choice in patients of gallstones has to be an ultrasound abdo beta. Reason definitely हमें पता है 90% gallstones are going to be radiolucent. मतलब they will appear black on an X-ray or a CT scan. So investigation of choice has to be an ultrasound abdo beta. Whereas for urinary stones, the investigation of choice will be a NCCT abdomen. That is a non-contrast CT scan. Now यहाँ पे अगर देखोगे how to differentiate a gallstone sorry, gallstone and gallbladder polyp में differentiate करने के लिए posterior acoustic shadowing is important. What will have a shadow, polyp or stone? तो हमें पता है that all the gallstones will have a posterior acoustic shadowing. Polyps will never have any kind of posterior acoustic shadowing बेटा. तो यहाँ पे as posterior acoustic shadowing is present definitely. तो please remember बेटा, this is a classical picture of a gallstone definitely. It is a classical picture of a gallstone बेटा. अगर वो पूछेंगे what should be the treatment in a patient of gallstones? The treatment in patients of gallstone is a gallbladder removal. That is nothing else but cholecystectomy beta. Now, cholecystectomy, either it can be done via open or a laparoscopic approach, bache. For open cholecystectomy, the incision that we use is known as Kocher's incision. For open cholecystectomy, the incision that we tend to use beta is known as a Kocher's incision in the right hypochondrium. That is important to be remembered. Sometimes we don't usually do a CCT for gallstone. In case if we do, this kind of appearance is seen. क्या बोलते हैं इसको? It is the Mercedes Benz sign. तो अगर ट्राई रेडिएट गॉलस्टोन होता है बेटा तो वी आर एबल टू सी अ क्लासिकल मर्सिडीज बेंज साइन डेफिनेटली ऑन द सीसीटी abdomen of the patient बेटा. ठीक है. Next important if I talk about done. Next important if I talk about beta, it is nothing else but this next picture which you are able to see. And what is this picture? Very good. So this condition which is there beta, it is nothing else but cholesterolosis. So if I talk about cholesterolosis of gallbladder, it gives which kind of appearance? Strawberry like appearance beta. तो अगर वो बोलते हैं strawberry gallbladder is a feature of, answer is cholesterolosis of gallbladder. Do we need a cholecystectomy? No. Please remember that cholesterolosis is not a pre-malignant condition, beta. Therefore, no cholecystectomy is usually required in a patient of cholesterolosis of gallbladder. Strawberry gallbladder and cholesterolosis. Strawberry vagina in trichomoniasis. Strawberry gums in vaginous granulomatosis. So strawberry gums are a feature of vaginous granulomatosis. Strawberry tongue in Kawasaki disease and scarlet fever beta. That is important. Chalo. Next, what is this condition? Very good. Here you are able to see there is calcification in the gallbladder wall. And calcification in the gallbladder wall is a classical picture of porcelain gallbladder. Please tell me, in porcelain gallbladder, do we need a cholecystectomy? Yes, reason porcelain gallbladder is going to be a pre-malignant condition. As porcelain gallbladder is a pre-malignant condition, therefore it increases the risk of gallbladder cancer beta. And therefore cholecystectomy is always required in patients of porcelain gallbladder when the gallbladder wall is calcified. Clear? This has been a previous year image-based question. Next important if I talk about beta is this classical feature. क्या क्या दिख रहा है? First of all, you are able to see pneumobilia बच्चे. What is pneumobilia? Air or gas inside the gallbladder. So if air or gas is present in the gallbladder, that is called as pneumobilia. Second, you are able to see multiple air fluid levels beta. And multiple air fluid levels is feature of small bowel obstruction. And third, you are able to see a radio opaque shadow in the terminal ileum beta. That is nothing else but the gallstone. So gallstone in the terminal ileum. This is called as which triad? This classical triad is going to be called as the Regular's triad beta. This classical triad is known as the regular triad, and regular triad is a feature of which condition? Gallstone ileus. So हमें पता है in case if there is formation of a fistula between the gallstone and the duodenum, one of the between the gallbladder and the duodenum, one of the gallstone will go into the duodenum and it will travel up to the terminal ileum, causing a small bowel obstruction beta. And that condition is classically called as a gallstone ileus. The patient will be brought to us in the emergency beta with the complaints of intestinal or bowel obstruction, बच्चे. We will start doing the conservative management in the patient for bowel obstruction, but we find that the patient's condition does not improve क्योंकि वो gallstone अभी भी उधर ही है. So इसीलिए the patient's condition will not improve just by conservative management, and that's the reason why we will take up our patient for a exploratory laparotomy. And once we have gone for an exploratory laparotomy beta, then we have to do a enterotomy, and ultimately we have to do a stone removal beta. So we will do an exploratory laparotomy, then perform an enterotomy, and then ultimately remove the stone. So that is the treatment in a case of a gallstone ileus, where regular steroid is going to be seen. Understood? Next important is this case beta, where they say a patient presents to you with sudden onset right upper quadrant pain along with fever, nausea, and vomiting beta. The sign given below is elicited. What is Murphy's sign? So please remember, in cases when the patient is going to have a severe abdominal pain, if you try to palpate the patient's right hypochondrium beta, the patient is having such a severe pain that the patient catches his breath. अचानक से सांस रुक जाती है दर्द के मारे. And this is classically known as the Murphy's sign. All these symptoms along with Murphy's sign is a classical diagnosis of acute cholecystitis beta. So Murphy's sign is a very, very classical feature found in the patients who are suffering from acute cholecystitis. Now we know acute cholecystitis can be of two types. Either it is calculus or the acalculus. Matlab, if it is due to gallstones, we are going to call it as calculus cholecystitis. If it is without any gallstones, we are going to call it as acalculus cholecystitis beta. अब जो भी टाइप का जिस भी टाइप का acute cholecystitis है, what is the investigation of choice? We know investigation of choice in patients of acute cholecystitis has to be an ultrasound abdomen. And once you diagnose this case, basically beta, okay, with the help of an ultrasound abdomen, what should be the treatment? So please remember, in patients of acute cholecystitis, you should go for a conservative management or a cholecystectomy. In patients of acute cholecystitis, we initially always go for a conservative management beta. The same things that we have done earlier, conservative management has to be done. In case if the patient has presented to us early beta, like within 1 or 2 days of symptom onset, then I can go for an emergency cholecystectomy. But if my patient has presented to me late after 3 to 4 days of the symptom onset, then we do a conservative management and then we discharge the patient after improvement beta and then go for a इंटरवल कोलेसिस्टेक्टमी 6 वीक्स लेटर, क्योंकि जब अडेजेंस होता है तब इमरजेंसी कोलेसिस्टेक्टमी शुड नॉट बी डन। क्लियर है बात? सो दैट इज व्हाट इज इंपॉर्टेंट टू बी रिमेंबर। तो कंजर्वेटिव मैनेजमेंट प्लस माइनस कोलेसिस्टेक्टमी आई एम राइटिंग। कोलेसिस्टेक्टमी डिपेंड्स व्हाट इज द टाइम ऑफ प्रेजेंटेशन। जल्दी आया तुम्हारे पास तो कर दो कोलेसिस्टेक्टमी, लेट आया है तो 6 हफ्ते बाद करो फिर, ठीक है? Done with this. Now answer the question. Now, question is, a 52-year-old woman beta on the waiting list for a laparoscopic cholecystectomy has been admitted as an emergency case beta with increasing right upper quadrant pain. Along with that, she's having a swinging pyrexia or fever, and there is extreme tenderness beta over the gallbladder, that is in the right hypochondrium. The patient is appearing toxic and has leukocytosis with raised inflammatory markers that is strongly suggestive of an infection or inflammation beta. Ultrasound of the gallbladder shows there is a thickened gallbladder beta that happens due to inflammation or cancer, enveloped by an omentum with pericholecystic fluid. What is the likely diagnosis of the patient? Answer A, B, C, D. Now, let's talk about one by one. What is the first thing that you are going to rule out? Hmm? The first thing I can rule out easily is a biliary colic beta. Biliary colic means when there is a stone inside the common bile duct and that is causing pain beta. That is what is called as a biliary colic basically. Biliary colic अगर होता बेटा तो definitely right upper quadrant pain होता, but उसके अलावा fever and leukocytosis with raised inflammatory markers will not be a feature. Next important, carcinoma of gallbladder is another one that I can rule out. Yes, thickened gallbladder wall can be seen in cases of carcinoma beta, but signs of infection or inflammation will not be a feature of carcinoma. We are left with two conditions. One is acute cholecystitis, second is empyema of the gallbladder. What seems to be more correct? Option D, that is empyema of the gallbladder, has to be the answer. Empyema is nothing else but pus collection beta. ठीक है? Acute cholecystitis भी हो सकता था, but definitely here the infection or inflammation is much more severe. The patient is toxic. Okay, and definitely the gallbladder has been enveloped by omentum along with collection of pericholecystic fluid. So as the patient is more toxic, therefore I am marking it as empyema. If empyema was not an option, I would have marked it as cholecystitis itself. Clear है बात अभी? Chalo. Next important, if they ask you another case, it is of a bile duct injury. A patient was diagnosed as a case of acute cholecystitis and he was a known case of gallstone. The patient was managed conservatively beta and then planned for an interval cholecystectomy 6 weeks later. Patient undergoes a lap chole, that is a laparoscopic cholecystectomy. He started developing pain in the right hypochondrium along with complaints of fever, and the ultrasound abdomen was done, which reveals a 5 by 4 centimeter of fluid collection under the liver, that is in the hepatorenal pouch. There is collection of around 5 by 4 centimeters of fluid. What shall be done next in this condition? तो हमें पता है the patient has undergone with surgery, laparoscopic cholecystectomy. During that surgery, maybe the bile duct of the patient has got injured, and due to that, after the surgery, the bile has started leaking out. And as there was a lot of bile leak beta, all that bile has collected in the hepatorenal pouch beta, and therefore you are able to see a 5 by 4 centimeters of fluid collection basically bache. That is nothing else but collection of bile, and collection of bile is known as bilioma. So this fluid collection that you are able to see on an ultrasound beta is nothing else but a case of bilioma. Now, what shall be done next? They are asking you. I've told you, bilioma happens in minor league or major leagues. Only in major league beta. Matlab patient has undergone a surgery. Due to that, there was a bile duct injury. Okay, and due to that, there was a major leak. उस major leak की वजह से the patient is having a bilioma beta. अब अगर किसी patient में bilioma होता है, what is the first step to be done? Bilioma के cases में, whenever the patient comes to us after surgery, the first step is always an ultrasound abdomen. Don't you want to see the fluid collection in the abdomen? So first step is always an ultrasound abdomen. After ultrasound abdomen is done, then जितना भी fluid collection है वो हटाना या नहीं हटाना? So for that, the next step should be, I have given this to you stepwise and I have told you कि stepwise आता है exam में. So next step is going to be a pigtail catheter insertion for the purpose of drainage. right? So pigtail catheter insertion and drainage should be done beta in the next step. Once you have drained the bilioma beta, uske baad you will try to look out for the bile duct injury. And what is the investigation of choice for bile ducts? MRCP. So once you have definitely beta drained the bile collection or the fluid collection, you go for a MRCP, that is magnetic resonance cholangiopancreatography. In case if MRCP fails to give you a diagnosis, then you go for a gold standard investigation, and that is ERCP. So either go for a MRCP or a ERCP. And once you have diagnosed, okay, what is the site of injury, what is the site of leak, how much is the extent of the bile duct injury, then you will go for the treatment beta. Now, treatment depends whether the patient has presented to you within 2 days of surgery or after 2 days of surgery. If my patient has presented to me early, that is within 2 days of surgery, chances of infection and sepsis will be more or less less. So can I take my patient back to the OT and go for a re-exploration and repair? Yes. But if my patient has presented to me late beta, that is after 3 days of surgery, then now definitely beta, the chances of sepsis will be more. And therefore I should go for ERCP with stenting beta. I should just go for a temporary relief of that bile leak beta, and that is ERCP with stenting. तो यहाँ पे next step बताओ क्या करोगे? Ultrasound has been done, उन्होंने बोला है, okay, on which fluid collection was seen. So now next step has to be pigtail catheter insertion and drainage. ERCP with stenting will be done beta after the diagnosis and the site of injury has been confirmed. ठीक है, anastomosis over T tube is not done after the surgery, it is only done during the surgery. And MRCP, it will be done after pigtail catheter insertion has been done and the drainage of fluid has happened. Clear? चलो, तो if I talk about bile duct injury बच्चों over here, तो याद रखना bile duct injury can present to us in two ways beta. First, definitely it can present to us during the surgery or it can present to us after the surgery. First, if the patient is having a bile duct injury during the surgery, मतलब surgery चालू है तब bile duct injure हो चुकी है and it is just a partial injury, what we should go for? I should just go for an immediate repair. Reason, it is only a partial injury, and second important, surgery is also going on. So immediately go for repair. Clear? Next important, if there is a complete transaction is a complete cut. But here definitely there is no loss of segment. कोई bile duct का piece missing नहीं है. ठीक है? तो if there is complete transaction and no loss of segment, so I can just go for connecting the bile duct beta together, that is anastomosis. And whenever we repair the bile duct via anastomosis, I have to insert which tube? T tube beta. So anastomosis over a T tube has to be done. Next, if there was a complete transaction of the bile duct during surgery, but loss of segment is there, मतलब some part of the bile duct has gone missing, कुछ हिस्सा गायब हो चुका है. अब अगर bile duct का कुछ हिस्सा गायब है बेटा, तो can you do an anastomosis over here? No. So then directly we will pull up jejunum and directly jejunum को connect कर दो बेटा bile duct या hepatic duct के साथ, and that connection between bile duct and hepatic duct is known as Roux-en-Y choledochojejunostomy or a hepaticojejunostomy. So Roux-en-Y hepaticojejunostomy or a choledochojejunostomy, whatever is possible, you have to do that. ये तो हो गया ड्यूरिंग सर्जरी, जब सर्जरी चालू थी और बाइल डक्ट इंजर हुई थी. इन केस patient has presented to you after the surgery has been completed, and if it is a case of a minor leak के cases में there will be no chances of sepsis and the patient will be stable. Treatment, we will just go for conservative management and no intervention would be done बेटा. ठीक है, तो माइनर लीक अगर है तो अपने आप ठीक हो जाता है, नो इंटरवेंशन इज यूजुअली रिक्वायर्ड. अगर मेजर लीक है, इफ इन केस देयर वाज अ मेजर लीक दैट वाज आइडेंटिफाइड आफ्टर द cholecystectomy surgery, then definitely what we have to do beta, if the patient has presented to us early, that is within 48 hours, तो ये सब सेम स्टेप फॉलो होगा. आफ्टर सर्जरी जब भी पेशेंट आता है तुम्हारे पास, पहला अल्ट्रासाउंड, फिर पिगटेल कैथेटर इंसर्शन एंड ड्रेनेज, फिर एमआरसीपी ईआरसीपी टू आइडेंटिफाई. जब एमआरसीपी और ईआरसीपी करके हो चुका है, नाउ वी विल प्रोसीड फॉर ट्रीटमेंट. अब ट्रीटमेंट की जब मैं बात करता हूं, इफ पेशेंट हैज प्रेजेंटेड टू अस अर्ली विद इन 48 आवर्स, वी गो फॉर री-एक्सप्लोरेशन एंड रिपेयर बेटा. इधर इमीडिएटली री-एक्सप्लोरेशन एंड रिपेयर कर सकते हो, बट इफ द पेशेंट हैज प्रेजेंटेड टू यू आफ्टर 2 days ऑफ सर्जरी बेटा, So in this condition, definitely we don't go for an immediate re-exploration and repair. We go for an ERCP with stenting, bache. So ERCP with stenting has to be done. No issues with this, anybody? Chalo. Next is a case, beta, and that states that we have a neonate who has a progressive jaundice since birth, beta. Child is also having pale colored stools. LFT, that is liver function test, shows there is raised levels of ALP or alkaline phosphatase. What is the likely diagnosis? Very good. अब इतना तो clear है that the patient is having jaundice since birth. So it is a physiological or a pathological jaundice? Pathological. हमें पता है that physiological jaundice always appear from day 2, never on day 1. So it is a pathological jaundice. Second important, the patient is having definitely pale stools, beta. Pale stools and dark urine are a feature of obstructive jaundice or a post-hepatic jaundice when there is problem at the level of bile ducts, beta. Third important feature which confirms it is the raised ALP level. हमें पता है ALP, that is alkaline phosphatase, is a very specific enzyme for the bile duct pathologies. तो अगर bile duct में कोई दिक्कत है तब ALP बढ़ता है बेटा. That is what is important. So here it is a very classical diagnosis of biliary atresia. What is biliary atresia? When the bile ducts do not develop because of inflammatory fibrosis during the fetal life. That condition is known as biliary atresia. तो अगर bile duct ही नहीं बने बेटा तो will the bile be able to drain? No. That is the reason why there is an obstructive jaundice which is progressive in nature since birth, beta. Clear? We know there are mainly three types of biliary atresia. Type 1 biliary atresia में what is not formed? Type 1 is a CBD atresia, common bile duct atresia. Type 2 में what is not formed? Common hepatic duct. Type 2 is a common hepatic duct or a CHD atresia. And type 3, which ducts are not formed? All ducts. Matlab, common bile duct, common hepatic duct, cystic duct, right and the left hepatic duct. Nothing is formed. जब कुछ नहीं बनता, that is what is a type 3 biliary atresia, beta. Understood? That is what is important to be remembered. Ab, in cases of biliary atresia, bache, if they ask you that when the child has been brought to you, what is going to be the investigation of choice? It is going to be a HIDA scan, beta. So HIDA scan, that is hepatic immunodiacetic acid scan, beta, is going to be the investigation of choice. But for intrahepatic atresia, what is the best investigation? Very good. For intrahepatic atresia, the best investigation is always a liver biopsy, beta. That is important to be remembered. अगर वो पूछते हैं treatment now, so please remember, if I talk about type 1 में what is not formed? Common bile duct is not formed. So if CBD is not formed, I can connect the jejunum directly to the common hepatic duct, and that surgery will be called as the RU-NY, hepatico-jejunostomy. So type 1 के problem में बेटा we can go for a RU-NY hepatico-jejunostomy. But type 2 हो या type 3 हो, इसमें majority ducts are not formed, beta. As the bile duct or the biliary tree is not properly developed over here, here we connect the jejunum directly to the porta hepatis, which is present below the liver, called as portoenterostomy, also called as with surgery. Very good. It is also known as the Kasai surgery or the Kasai operation. So that Kasai surgery will be done for type 2 and type 3 biliary atresia. Next, this is the picture, beta. क्या दिख रहा है ये? What is this investigation? It is a T-tube cholangiogram. It is neither a ERCP nor a MRCP. It is just a X-ray basically, जहाँ पे तुम्हें दिख रहा है क्या? T-tube has been inserted. So this is a T-tube cholangiogram. That's it. Next, what is this investigation? Now this is basically ERCP, beta, which is gold standard investigation for biliary tree pathologies, beta. Endoscopic retrograde cholangiopancreaticography. ERCP क्यों? Because you are able to see the endoscope. As the camera has been turned retrogradely, beta, therefore you are able to observe the endoscope basically, and this is a case of ERCP, and all the bile ducts are visible. Clear? That is important. MRCP पे कोई endoscope नहीं होता बेटा. It is a non-invasive investigation. It is just a T2 weighted MRI of the bile ducts. Clear? So now if I talk about the next one, that is nothing else but choledochal cyst, beta. If I talk about choledochal cyst, we know it is cystic dilatation of the common bile duct or the other bile ducts beta. Choledochal cyst में as there is dilatation of the bile ducts बच्चे, there is retention or stasis of bile over here. ठीक है? And the patient will present to you with a very classical triad known as the choledochal triad. What is the choledochal triad? बोलो. Pain, lump, and jaundice. Please remember, pain, lump, and jaundice will be the classical triad. Why lump? Because it is a case of a choledochal cyst beta. So when you palpate the abdomen, you are able to feel this cyst as a lump beta. So pain, lump, and jaundice is the choledochal triad of choledochal cyst. Pain, fever, and jaundice. Intermittent pain, fever, and jaundice is a case of Charcot's triad. तो पेन फीवर एंड जॉन्डिस शार्कॉट्स ट्रायड होता है बेटा वो, और फीवर तब होगा जब इन्फेक्शन होगा. तो पेन फीवर एंड जॉन्डिस is Charcot's triad, which is a feature of cholangitis. Cholangitis is an infection of the bile ducts. ठीक है? तो cholangitis के केसेस में Charcot's triad होता है, that is pain, fever and jaundice. अगर cholangitis के केसेस में along with the Charcot's triad of pain, fever and jaundice, if I add hypotension, that is low BP, along with mental confusion, that is a case of Raynaud's pentad. तो cholangitis के केसेस में there is a Raynaud's pentad where there is pain, fever, jaundice plus hypotension plus mental confusion beta. Clear? Chalo. Now if they ask you what is the classification used for choledochal cyst, so we know the classification used for choledochal cyst is Todani's classification, also known as the modified Alonso-Ledge classification beta. And according to Todani's classification, the choledochal cyst is classified into 5 types, where the 4th type is subdivided into 4A and 4B. अगर टाइप 1 की बात करें अपन, तो टाइप 1 में डेफिनेटली बेटा यू आर एबल टू सी अ सिंगल और अ सॉलिटरी एक्स्ट्रा हेपेटिक सिस्ट इन विच डक्ट, कॉमन बाइल डक्ट. टाइप 2 में बेटा there is not a cyst but rather an outpouching called as a extra hepatic diverticulum बचे. Again in which duct? Common bile duct. Type 3 में you can see the intramural or the intraduodenal part of the CBD is dilated, called as choledococele beta. Type 4A में there is single or multiple cyst. The type 4A में there are multiple cysts. Intrahepatic or extrahepatic? Both beta. तो याद रखना type 4A में there are multiple extra as well as intrahepatic cysts, that is type 4A. Type 4B में again there are multiple cysts but all of them will be extra hepatic. So type 4A में there will be multiple extra hepatic cysts only, whereas type 5 में again there are multiple cysts, but in type 5 all the cysts are going to be within the liver. So in type 5 there are multiple intrahepatic cysts. Type 5 choledochal cyst is also called as the Caroli's disease. So previous year question was Caroli's disease is which type of choledochal cyst? Answer has to be type 5 choledochal cyst is Caroli's disease beta. Hopefully understood. So एक बार, what is the name of classification? Todani's classification beta. Type 1 में single extrahepatic cyst in the common bile duct. Type 2 में extrahepatic diverticulum. Type 3 is choledococele. Type 4 is multiple extra as well as intrahepatic cyst. Type 4B only multiple extrahepatic cyst, and type 5 is multiple intrahepatic cyst. Investigation of choice, bile duct की problem है. Investigation of choice definitely in a case of choledochal cyst beta, answer has to be MRCP, which is a non-invasive investigation. But अगर gold standard पूछा जाए तो the gold standard investigation that you are going to perform in a choledochal cyst, answer is ERCP. Why? ERCP is considered as gold standard investigation in choledochal cyst or any bile duct pathologies because it is not only diagnostic but even therapeutic. Also helps us in treatment beta. That is what is important to be remembered. ठीक है? एक बार बस मैं शॉर्टली ट्रीटमेंट बता रहा हूँ. ट्रीटमेंट टाइप 1 में सिंगल सिस्ट है और वो भी सीबीडी में है बेटा. तो इसमें हम क्या करेंगे? वी आर एक्चुअली गोइंग टू रिमूव द कॉमन बाइल डक्ट and we will connect our jejunum to the common hepatic duct. So type 1 में we go for a Roux-en-Y hepatico-jejunostomy. तो type 1 में बेटा you have to go for a Roux-en-Y hepatico-jejunostomy. Type 2 में there is only a diverticulum बेटा. तो इसमें we will cut the diverticulum and we will just repair the common bile duct. That is what is done. Type 3 में why there is choledococele? Because the opening of the common bile duct is very very narrow. You have to widen up the opening. उसके लिए we go for ERCP with sphincterotomy बेटा. ERCP with sphincterotomy will be done. जिसमें क्या होगा, स्पिंक्टर्स के ऊपर अपन कट लगाएंगे तो द स्पिंक्टर्स इज गोइंग टू रिलैक्स एंड द ओपनिंग इज गोइंग टू वाइडन अप. नेक्स्ट टाइप 4A एंड टाइप 5 में क्या कॉमन चीज है? तो हमें पता है दैट टाइप 4A हो या टाइप 5 हो, दोनों में कॉमन फैक्टर क्या है? दोनों में देर आर मल्टीपल इंट्रा हेपेटिक सिस्ट. और जब भी इंट्रा हेपेटिक सिस्ट होगा बेटा तो नो ट्रीटमेंट इज पॉसिबल एक्सेप्ट लिवर ट्रांसप्लांट. द ओनली ट्रीटमेंट फॉर इंट्रा हेपेटिक सिस्ट इज अ लिवर ट्रांसप्लांट टू बी डन. एंड लास्टली टाइप 4B अगर होगा बेटा तो टाइप 4B में वी हैव टू रिमूव द कंप्लीट बाइल डक्ट आउटसाइड द लिवर एंड कनेक्ट द इंटेस्टाइन डायरेक्टली टू द पोर्टा हेपेटिस, दैट इज पोर्टोएंट्रोस्टोमी, आल्सो नोन एज Kasai surgery or the Kasai operation. Hopefully clear to all of you now. And identify. This was a previous year FMG exam question. Which among the following is a type 3 choledochal cyst according to the Todani's classification? Type 3 क्या होता है? Type 3 basically is choledococele. That is the intraduodenal portion of the CVD is dilated. Beta. What is the answer? Answer has to be option B, जहां पे definitely बेटा choledococele is observed. Type A, sorry, A जो है वो that is which type? Type, sorry, the option A which is there beta, it is type 1 basically. Why? Because here there is a single extrahepatic cyst in the common bile duct. Clear? Next, C कौन सा है? ऑप्शन सी जो है बेटा इट इज टाइप 4B. रीजन, यहाँ पे देर आर मल्टीपल एक्स्ट्रा हेपेटिक सिस्ट ओनली. तो अगर मल्टीपल एक्स्ट्रा हेपेटिक सिस्ट दिखेंगे बेटा तो इट हैज टू बी अ टाइप 4B. डी, ऑप्शन डी कौन सा है? तो प्लीज रिमेंबर बेटा ऑप्शन डी इज गोइंग टू बी टाइप 4A बिकॉज देर आर मल्टीपल एक्स्ट्रा एज वेल एज इंट्रा हेपेटिक सिस्ट बेटा. क्लियर है बात? चलो, लेट्स स्टार्ट विद यूरोलॉजी नाउ. If I talk about urology, beta, the first condition that you are able to see. So, यहाँ पे we will do a CCT abdo. On that CCT abdo, I am able to see. On CCT abdomen, no flower was seen. It is seen on IVP. ठीक है? So please remember on the CCT abdomen, beta, I am able to see definitely both the kidneys are going to be ectopic in nature. And both these ectopic kidney, इनका जो lower pole होता है बेटा, their lower pole is fusing with each other. So ectopic kidneys beta with the lower pole fusing with each other is a case of horseshoe kidney beta. अब हमें पता है that horseshoe kidney में definitely what is the most common site of fusion? तो हमें पता है that horseshoe kidneys में the lower pole of the kidneys beta most commonly fuse at the site of L3 L4 beta. Most common site of fusion is L3 L4. That is important. Horseshoe kidney में patient will not be able to drain properly, causing urine retention, and that will increase the risk of UTI or stones beta. अब मुझे बताओ in patients of horseshoe kidney, if I do a IVP, that is the intravenous pylography, what is the appearance seen? We are able to see the classical flower vase appearance. So classical flower vase appearance is going to be seen beta, also called as the hand joining sign or the hand shaking sign. So intravenous pylography shows me a flower vase appearance or hand joining sign or the hand shaking sign, we call it as. Treatment is going to be surgical or conservative. याद रखना in patients of horseshoe kidney the management is always conservative. We will never try and cut the lower pole. If you try to cut the lower pole beta, the kidneys will get damaged. Only a conservative management is done. Next is a picture beta. तो यहाँ पे it is a classical picture of IVU, that is the intravenous urography. And on that intravenous urography you are able to see in the pelvis both the ureteric openings have been dilated beta because the ureteric opening is very very narrow, and this gives a very classical appearance called as It is the classical cobra head, also known as the adder head appearance. और हमें पता है whenever cobra or adder head appearance is going to be observed, it is a classical picture, classical case of uretrosil. तो याद रखना cobra or adder head appearance basically beta is a diagnosis of uretrosil. And if you talk about uretrosil, we know uretrosil happens more commonly unilaterally or bilaterally. Uretrosil is 90% cases में unilateral, only 10% cases में it is going to be bilateral beta. One thing. Next, uretrosil happens because the ureteric openings into the urinary bladder are wide or narrow. Narrow. As the ureteric openings are very narrow beta, therefore uretrosil develops. Important. अगर उन्होंने पूछ लिया कि what should be the treatment in patients of uretrosil, बोलो. Better treatment will be incision at the ureteric orifice or ureteric reimplantation. तो हमें पता है द बेटर ट्रीटमेंट फॉर यूरेट्रोसील इज ऑलवेज अ यूरेटरिक रीइम्प्लांटेशन बेटा. नई ओपनिंग बना दो यूरेटर्स के लिए इन द यूरिनरी ब्लैडर. रीजन, if you only give a incision or if you only make an incision beta at the ureteric orifice, sometimes the ureteric openings will become very very big in size beta, and due to that the patient will have a very very high risk of vesico-ureteric reflux. That is the problem. Clear? So ureteric reimplantation is a better surgery. Next important, another IVP. So in this picture beta that you are able to see, this is intravenous pylography giving you a very classical appearance. जहाँ पे the lower pelvis appears to be drooping downwards beta. Why lower pelvis I am saying? Because normally each kidney has only one renal pelvis, but इस condition में there would be two renal pelvis beta. So it is a case of duplication or duplex renal pelvis and ureter. तो एक की जगह दो pelvis और दो ureters होते हैं किडनी में बेटा. So this is classically known as which sign? Drooping lily sign. So if you see the IVP beta, you are able to see a very classical drooping lily sign. And drooping lily sign on IVP is a classical feature of duplex renal pelvis and ureter. It is a classical feature of duplex renal pelvis and ureter beta that has to be kept in mind. Now, if see both the ureter which is there definitely beta, if they are opening into the urinary bladder, patient will have no problem. बट अगर गलती से भी एक भी यूरेटर अगर एक्टोपिक हो जाता है, लाइक इवन इफ वन ऑफ द यूरेटर बिकम्स एक्टोपिक बेटा, if it is opening at some unusual site like in the urethra, then the patient will suffer from problems bache. And in those conditions I have to do a ureteric reimplantation of both ureters or only the ectopic ureter. ओनली द एक्टोपिक यूरेटर. जो यूरेटर गलत जगह पे ओपन हो रहा है उसको ब्लैडर में ओपन करवा दो. ठीक है? सो दैट इज व्हाट इज यूरेट्रिक रीइम्प्लांटेशन ऑफ द एक्टोपिक यूरेटर टू बी डन. दैट इज इंपॉर्टेंट. Next, if I talk about यहाँ पे a neonate has been brought to you beta, and that neonate is basically having this kind of appearance जहाँ पे the child was having a severe urine retention. Along with severe urine retention, you are able to see that the patient's renal pelvis and the renal calyces have got dilated, and there is some obstruction basically at this level. What is this? Hydronephrosis. Due to what reason? Very good. PUJ obstruction. It is a classical case of pelvi-ureteric junction obstruction. See, dilatation of renal pelvis and calyces is called as hydronephrosis. But hydronephrosis हुआ क्यों इस बच्चे में? तो hydronephrosis हुआ because there is some obstruction at the pelvi-ureteric junction. हमें पता है ना, most common cause for hydronephrosis which is there बेटा. Most common cause for hydronephrosis if I talk about बच्चे, please remember it is going to be stones. But most common congenital cause of hydronephrosis is PUJ obstruction. बराबर? So that is important to be remembered बेटा. तो यहाँ पे जो दिख रहा है ये hydronephrosis होगा definitely. But that hydronephrosis is mainly due to what reason? तो याद रखना, due to PUJ obstruction. If they ask you PUJ obstruction or pelvic-ureteric junction obstruction जो होता है, what is the treatment for that? जो पेल्वी यूरेट्रिक जंक्शन है वहां पे देयर इज अ एडायनेमिक ऑब्स्ट्रक्शन, मतलब उतना पार्ट कोई मोटिलिटी नहीं दिखा रहा, इसकी वजह से यूरिन पास नहीं हो पा रही प्रॉपर्ली. तो हम क्या करेंगे, उस पार्ट को कट करेंगे और बाकियों को जोड़ देंगे. दैट इज रिसेक्शन एंड एनास्टोमोसिस. दिस सर्जरी इज नोन एज, इट इज क्लासिकली नोन एज एंडरसन हाइनीज पाइलोप्लास्टी बेटा. Pyeloplasty is repair. So please remember Anderson Heiney's pyeloplasty is the treatment that we perform for a pelvic-ureteric junction or a PUJ obstruction. Next is a picture beta, जहां पे क्या दिख रहा है? Definitely here you are able to see that the right sided ureter has taken a turn beta, and it is going behind the inferior vena cava, and as it is taking a turn there is obstruction to the flow of urine beta, जिसकी वजह से there is severe retention of urine that is causing hydronephrosis. So again there is dilatation of pelvis and callisis causing hydronephrosis, but वो hydronephrosis का कारण क्या है? वो कारण है the right ureter going behind the vena cava. And when ureter goes behind vena cava, it is called as, yes, it is a classical diagnosis of retrocaval ureter. If I talk about retrocaval ureter beta, which is the classical appearance seen over here? Very good. तो ये जो retrocaval ureter है, इसमें ये जो shape दिख रहा है, this is called as reverse J-shaped ureter, also known as face shook ureter beta. Sorry. Either you will call it as the reverse J-shaped ureter beta or the face shook ureter. In cases of retrocaval ureter, if you want to lateralize the ureter beta, okay, here it is going medially na, behind the vena cava. So if you have to lateralize the ureter, I have to insert some stent inside the ureter. The stent that is inserted in the ureter is called as DJ stent. That is called as double J stent beta. That is important to know. Understood? The last picture that you are able to see, कौन सा appearance दिख रहा है? This is an intravenous pylography showing you dilatation of the collecting ducts. And when dilatation of collecting ducts is seen, that is classically showing you a paint brush appearance. अगर paint brush appearance दिखता है, तो the diagnosis of the patient is a case of medullary sponge kidney beta. So it is a classical diagnosis of medullary sponge kidney. Okay, and the classical appearance that is seen over here is nothing else but a paint brush appearance. Understood? These are the diagnoses. Huh? डायग्नोसिस और साइन में गड़बड़ मत कर देना बस, ठीक है. नेक्स्ट इंपॉर्टेंट इफ आई टॉक अबाउट डन. नेक्स्ट इंपॉर्टेंट इफ आई टॉक अबाउट, दिस इज अ वेरी कॉमन कंडीशन. बोलो. So here you are able to see in both the kidneys beta there are multiple fluid filled lesions, and these multiple fluid filled lesions are known as cyst beta. Okay, and due to that both the kidneys have got enlarged, and as both the kidneys will get enlarged due to the cyst beta, ultimately the cysts are going to destroy or damage the kidneys as well beta. Okay, causing compromised renal function. So it is a classical case of PCKD, and we know PCKD is nothing else but polycystic kidney disease beta. If I talk about PCKD or a polycystic kidney disease, it can be of two types. The infantile variety is going to be autosomal recessive, and the adult variety is going to be autosomal dominant. याद रखना, the infantile variety जो होता है बेटा, it is autosomal recessive, and here the patient does not survive. The patient usually dies in the uterus or in the first year of life. But जो congenital variety या फिर adult variety होता है, that is the more common one. The congenital or the adult variety of PCKD is known as autosomal dominant variety. For this, the gene mutation responsible is known as PKD beta. Okay, PKD1 or PKD2 gene mutation are responsible for this condition. याद रखना, तो PKD1 or the PKD2 gene mutation are responsible बच्चे, and due to them there is a polycystin protein mutation. ठीक है, so that is important. Now, important is the most common site beta for the cyst formation due to the gene mutation is obviously going to be the kidneys beta. The most common site is obviously the kidneys, but followed by kidneys, the second most common site will be the liver. The most common extra renal site अगर पूछा जाए for cyst formation, answer has to be the liver beta. Clear? Liver में भी बहुत सारे cyst बनेंगे. Important. If they ask you that this condition is commonly associated with which neurological condition, बोलो. पीसीकेडी के पेशेंट्स में ब्रेन में क्या होगा? वेरी गुड, अन्यूरिज्म्स. ठीक है, तो बेरी अन्यूरिज्म्स जो दिखते हैं डेफिनेटली दैट विल बी सीन इन पेशेंट्स हु आर सफरिंग फ्रॉम पीसीकेडी बेटा. दैट इज इंपॉर्टेंट टू बी रिमेंबर्ड. नाउ इफ दे आस्क यू इन पेशेंट्स ऑफ पीसीकेडी, autosomal dominant PCKD, the symptoms are going to only appear after what age? 30 years of age. The symptoms will appear after 30 because kidneys will get completely damaged after 30 beta. And the most common symptom of the patient will be hypertension. ठीक है, बाकी भी होंगे पेन, हेमाचूरिया, मास, ऑल ऑफ दैट, बट मोस्ट कॉमन विल बी हाइपरटेंशन. अगर वो पूछते इन पेशेंट्स ऑफ पीसीकेडी बेटा, what is going to be the treatment? The main symptom is hypertension, so the main treatment will be anti hypertensive drugs like drugs like Prils beta, that is ACE inhibitors, or Sartans beta, that is angiotensin receptor blockers. Okay, जब भी hypertension kidney disease की वजह से होता है, the best drugs to be used are either ACE inhibitors or ARBs. ये याद रखना. ठीक है. Next important beta, you can also go for deroofing of the cyst. Deroofing of the cyst is known as roofing surgery. But is it useful? No. क्योंकि तुम कितने cyst deroofed करोगे, वापस बन जाएंगे वो. ठीक है, तो रोफसिंग सर्जरी इज डीरूफिंग ऑफ द सिस्ट, नॉट वेरी यूजफुल. द बेस्ट ट्रीटमेंट फॉर पीसीकेडी इज renal transplant. The best treatment overall for a case of PCKD beta, answer is nothing else but a renal transplant to be done. अगर मैं renal transplant की बात करता हूं बेटा, please tell me which kidney is preferred from the donor. For renal or kidney transplantation, always the left kidney is preferred from the donor because the left renal vein is longer beta. And where do we place the left kidney? This donated kidney will be placed inside the right iliac fossa beta. That is a heterotopic transplantation. Blood grouping and HLA matching, is it mandatory or not mandatory? Yes, it is absolutely mandatory in a case of kidney or renal transplantation. Maximum risk of transplant rejection is seen in lungs. Maximum rejection of maximum organ transplant rejection is seen in lung transplant followed by kidney transplant. Clear? 80% rejection in lung, 50% rejection in kidneys. What is this? Why? Is it a X-ray or a IVP? So this investigation that you are given, beta, it is a X-ray KUB, kidney ureter bladder. Why I am saying it is X-ray? Because no ureter, no bladder is visible. अगर IVP या कोई भी contrast study होता, both of them should have been visible. Next, on X-ray, if something appears more white, it is either a bone, stone, or a calcification. Here, definitely there is a calcification, and it appears in the shape of kidney or pelvis. Kidney. So here the calcification is appearing in the shape of kidney. And when calcification appears in a shape of kidney, beta, it is classically known as putty kidney. Please tell me putty kidney is due to what condition? तो हमें पता है that putty kidney which is there beta, it is mainly due to renal tuberculosis. So whenever a patient is known to develop renal TB beta, due to that initially there will be ulceration in the kidney. After ulceration there will be pus collection in the kidney called as pyonephrosis. After that there will be caseous necrosis in the kidney called as putty kidney. After that there will be complete calcification and hardening of kidney called as cement kidney, and ultimately there will be autonephrectomy. Autonephrectomy is a feature of renal TB. Autosplenectomy is a feature of sickle cell anemia में there will be autosplenectomy beta. That is important. अब अगर renal TB की बात करते हैं, we know it is a urinary tract infection only ना. So when the patient comes to us, the main complaint of the patient is going to be, बोलो, the main complaint or the most common complaint. So please remember, in any kind of infection I have told you, or in any stones beta, the most common symptom is always increased urinary frequency. Patient को बार बार पेशाब के लिए जाना पड़ेगा. That is what is important. Next important, if they ask you, अगर we are suspecting an infection, we have to send analysis of urine beta. तो urine microscopy and urine culture has to be sent. जब urine microscopy करेंगे, सरकारी question बोलो क्या लिखेगा? तो द कीवर्ड ऑफ दिस केस इज गोइंग टू बी स्टेराइल पायूरिया. भले कितना बड़ा क्वेश्चन हो, if they have mentioned sterile pyuria, you have to think that it is a case of genitourinary tuberculosis beta. Sterile pyuria का मतलब pus cells are going to be present but bacteria is going to be absent. That is called as sterile pyuria. And if it is diagnosed as a case of renal tuberculosis beta, okay, then definitely the treatment, if they ask you, all types of TB are always treated by ATT, that is anti-tubercular therapy. See, anti-tubercular therapy is the mainstay of management. Iske alawa, whatever is the symptom, according to that, you have to decide the management. Like, for example, patient is having a calcification of the kidney, you can go for nephrectomy. Second, if the patient is having definitely strictures in the ureter, तो यूरेटर के स्ट्रक्चर अगर है तो उसको ओपन अप करने के लिए यू हैव टू इंसर्ट अ डी जे स्टेंट और अ डबल जे स्टेंट बेटा. ठीक है, सो दैट इज व्हाट इज डन. नेक्स्ट इंपॉर्टेंट इफ आई टॉक अबाउट इज दिस कंडीशन. Patient is having fever, pain in the lumbar region, and difficulty in urination. What is the likely diagnosis? Very good. It is a classical diagnosis of emphysematous pyelonephritis. What is emphysema? Collection of air beta. So here there is infection of the kidney and the renal pelvis, and there is collection of gas or air inside the kidney. That condition is emphysematous pyelonephritis. Here you are able to see this black appearance around the renal pyramids is nothing else but the air or the gas. So emphysematous pyelonephritis ka most common causes. Yes, most common cause of emphysematous pyelonephritis is E. coli. For emphysematous cholecystitis, it is Clostridium perfringens is the most common cause for emphysematous cholecystitis, but for emphysematous pyelonephritis, it is going to be Escherichia coli. Treatment is nothing else but antibiotics. Now, if they ask you about another condition that is nothing else but urinary stones. Now, whenever I talk about urinary stones, it is also called as urolithiasis. And when I say urinary stone, that is any stone that is formed inside the urinary tract, whether it is renal stones, that is nephrolithiasis, or it is bladder stone, that is cystolithiasis. Beta. Both of them will be included in the urinary stone. Most common type of urinary stone, batao. The most common type of urinary stones. Answer has to be the calcium oxalate stones, beta. So calcium oxalate are considered as the most common type of urinary stone. They are pH insensitive, beta. Second important, calcium oxalate stone are found in which condition? Hyperoxaluria. So in patients of hyperoxaluria, beta, you are able to find calcium oxalate stone. Well, calcium combines with oxalic acid, beta. That is important to be remembered. Next important, if I talk about beta, is that which infection is associated with triple phosphate stone. याद रखना, if the patient is having a triple phosphate stone, also called as the Struwite stone, तो triple phosphate और Struwite stone के साथ the infection that is very commonly associated beta is the Proteus infection or the Proteus mirabilis infection. ये बहुत common question आता है तुम्हारे एग्जाम में. Do remember this अच्छे से. Repeated question it is. We know that in cases of cystine urea beta, which stones are going to be formed? Cystine stones, and these are going to be the hardest renal stones. So अगर पूछा जाए कि which are the hardest urinary stones, answer are the cystine stones. And हमें पता है that cystine stones are found in patients suffering from cystine urea. Which type of urine? Very good. Cola urine, not cola colored. ठीक है, तो cola urine where cystine, ornithine, lysine and arginine are excreted out in the urine बेटा, वैसी urine को cola urine बोलते हैं, that is cystine urea. उसमें cystine stones बनेंगे. No issues with this. In patients of gout, which stones are formed? So those patients who are suffering from gout or any other type of hyperuricemia, beta, patient will have uric acid stones. Anybody, uric acid stones are radiolucent or radio opaque? हमें पता है that 90% of renal stones beta are always radio opaque, which will appear white on an X-ray or CT. But there are few urinary stones which are radiolucent, which will appear black. Those are Lux, L for lysine, U for uric acid, and X for xanthine. That is important. हमें पता है that whenever a patient comes to us with urinary stones, again the symptom is same, increased urinary frequency, and second important symptom is pain. तो increased urinary frequency and pain are the two leading symptoms in urinary stone. इसके साथ जब patient आता है तो I send a urine analysis or a urine microscopy. Urine microscopy जब करोगे तो you will be able to see different types of crystals beta. Depending on the shape of the crystals, definitely you can identify that which type of stone is present in the patient's urinary tract. पहला dumbbell crystals. So dumbbell shaped crystals are seen in monohydrate calcium oxalate stones. Envelope shaped crystals. तो हमें पता है दैट एनवलप शेप क्रिस्टल्स आर सीन इन डाइहाइड्रेट कैल्शियम ऑक्सलेट स्टोन्स। तो याद रखना, there can be two types of crystals in calcium oxalate stones beta, monohydrate are dumbbell shaped and dihydrate are envelope shaped. Important is if they ask you hexagonal or benzene ring shape, cysteine or cystine? Hexagonal or benzene ring shape structure is going to be the cystine stones definitely. ठीक है, तो hexagonal or benzene ring shaped are the cystine crystals. Next, coffin lid shaped crystals. तो हमें पता है that coffin lid shaped crystals are going to be seen in triple phosphate stones also known as struvite stones बेटा। तो याद रखना ट्रिपल फॉस्फेट या struvite stones जो होते हैं उसमें you are able to see coffin lid shaped crystals, irregular और universal crystals। हमें पता है that irregular or universal shaped crystals is going to be seen in uric acid stones बेटा, that has to be remembered। क्लियर है बात? Now, important is if I talk about what is going to be the first line investigation in a case of urinary stone. तो फर्स्ट लाइन इन्वेस्टिगेशन अगर पूछा जाए बेटा इन अ केस ऑफ यूरिनरी स्टोन, आंसर हैज टू बी अ एक्सरे के यू बी। जब हम बोलते हैं एक्सरे के यू बी, दैट इज एक्सरे किडनी यूरेटर एंड ब्लैडर। जब तुम एक्सरे करोगे एंड इन केस इफ यू आर एबल टू सी अ वाइट स्टोन विच इज टेकिंग द शेप ऑफ रीनल पेल्विस, दैट इज कॉल्ड एज। तो हमें पता है जब देयर इज अ लार्ज स्टोन विच इज टेकिंग द शेप ऑफ रीनल पेल्विस बेटा, ठीक है, दैट इज अ केस ऑफ स्टैगहॉर्न कैल्कुलाई। स्टैगहॉर्न कैल्कुलाई इज अ टाइप ऑफ ए स्टोन, ट्रिपल फॉस्फेट स्टोन बेटा। तो ट्रिपल फॉस्फेट स्टोन्स व्हेन दे ग्रो वेरी ह्यूज और लार्ज इन साइज बेटा, दैट इज कॉल्ड एज अ स्टैगहॉर्न कैल्कुलाई, दैट इज इंपॉर्टेंट। बट इन्वेस्टिगेशन ऑफ चॉइस फॉर यूरिनरी स्टोन आंसर विल बी NCCT, kidney, ureter, and bladder beta. So NCCT KUB is the investigation of choice for urinary stone, and here you are able to see a stone in the inferior calyx of the kidneys beta. What is the diagnosis in this X-ray KUB which has been given to you? Bladder stone or calcified fibroid? This was a previous year image-based question of FMG exam, and the diagnosis has to be a giant bladder stone. Reason it is having homogeneous calcification. Calcified fibroid में dot 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 दिखते हैं, that is heterogeneous calcification दिखता है। Clear है बात? So that is what is important to be remembered. अब हमें पता है that the main symptom in patients of urinary stones is always lumbar pain बेटा or the suprapubic pain. So, depending on the type of pain, we can actually identify the location of the stone as well, beta. First, if my patient is having a stone in the kidney, so there will be two options hai, fixed lumbar pain or radiating lumbar pain. तो हमें पता है that whenever the patient is only having a stone in the kidney beta, my patient is having a fixed lumbar pain that does not radiate at all. Second important, if my patient is having stone in any part of the ureter, doesn't matter whether it is only the upper third, individually देख लो छोड़ो, upper third ureter में, if they say upper third ureter में there is stone, then the pain will radiate to which side? When the stone is in the upper one third of the ureter, the lumbar pain radiates to perineum in females beta or scrotum in males. ठीक है, when the lumbar pain radiates to perineum in females and scrotum in males, that is what is called as upper ureteric stone. If the stone is at the level of the pelvic brim or when the stone is present in the mid ureter beta. So please remember, when the stone is at the level of pelvic brim or the mid ureter, patient has a lumbar pain, and that lumbar pain is going to be radiating to the inner thigh and secondly to the iliac fossa. So whenever there is a stone beta at the level of pelvic brim or the middle part of ureter, the pain usually radiates to the inner thigh and the iliac fossa. Next, when the patient is having a urinary bladder stone, the patient will have lumbar pain or suprapubic pain. तो हमें पता है that whenever the stone is going to be present inside the urinary bladder, patient is going to present to us with suprapubic pain beta, that is what is important. अगर वो बोलते हैं that the stone is present at the level of bladder neck or inside the urethra, तो bladder neck or urethral stone में patient will have a suprapubic pain but that will radiate to, हमें पता है that in bladder neck or urethra में the suprapubic pain is going to radiate to beta The tip of penis. So when suprapubic pain radiates to the tip of penis, that means the stone is in the bladder neck or the urethra itself. Hopefully clear. अब अगर वो बोलते हैं कि what should be the treatment, we know treatment of urinary stone depends on the location of the stone beta basically. So first of all, if I talk about if the stone is inside the kidney beta, ठीक है. Hmm. If the stone is inside the kidney, then we have to first of all see the size of the stone beta. In case if I say the size of the stone is less than 5 to 6 mm beta, patient will be symptomatic or asymptomatic. If the stone is really small, less than 5 to 6 mm beta, majority patients are asymptomatic. And the treatment in this condition should be observation beta. If the stone is very small, that is less than 5 to 6 mm, we go for a observation or conservative management. जहाँ पे we will give painkillers or analgesics to the patient. We will recommend plenty of fluids in the patient. Along with that beta, you will give syrups to the patient, which will dissolve the stone. That's it. ठीक है? But if the stone is going to be more than 5 to 6 mm in size beta, so when the stone is more than 5 to 6 mm, that is large in size, then we have to break down the stone into pieces. And once we break down the stone into multiple pieces, beta, those broken down fragments or the broken down pieces will automatically get excreted out via the patient's urine beta. And this procedure is classically called as ESWL, that is the extracorporeal shock wave lithotripsy. If I talk about this procedure, here you will fire shock waves onto the stone, which will break down the stone into multiple pieces. And then these multiple fragments or pieces of stone will try to get excreted out via the urinary tract. So when they form a line of stones or a street of stones in the urinary tract, that is called as Stern-Strasse phenomena. This was a previous year image-based question. So ESWL के बाद, when the stones are going to form a street of stones inside the urinary tract beta, that is classically known as, answer will be the Stern-Strasse phenomena. Understood? Next important if they say, done? Next important if they say beta that the stone is found inside the kidneys itself, bache. But when the stone is in the kidneys, ESWL is not possible in this case. Reason, two main reasons. First, if the stone is more than 2 centimeter in size, such large stones beta cannot be broken down by the process of ESWL. Second, if there is distal obstruction, matlab, even if you break the stone, there is obstruction in the urethra. Will the stone fragments come outside then? No. तो ये जो दो conditions होती है बच्चे, जहाँ पे the size of the stone is either more than 2 centimeter or when there is a distal obstruction beta in the tract. In those conditions, what is the choice? Very good. In those conditions, we go for PCNL, that is percutaneous nephrolithotomy. That is removal of the stone beta directly from the patient's kidneys or the pelvis via the lumbar area or percutaneously. Clear? So that is what is important. अगर मैं बात करूं यूरेट्रिक स्टोन्स की, हमें पता है that again in the ureter if the stone is very small in size, that is less than 5 to 6 millimeter in size, and it is not causing any obstruction as such beta, then we can just go for an observation along with conservative management. But agar stone is more than 6 if the stone is more than 5 to 6 mm in size, that is large in size, or second, if the stone is causing obstruction or it is impacted with अटक गया है, तो लार्ज स्टोन इन द यूरेटर और इम्पैक्टेड स्टोन इन द यूरेटर बेटा, इन दोनों कंडीशंस में द ट्रीटमेंट इज गोइंग टू बी URS. What is URS? Ureteroscopic removal of stone with the help of which basket? डॉर्मिया बास्केट. तो हमें पता है यूआरएस मतलब होता है यूरेट्रोस्कोपिक रिमूवल ऑफ स्टोन करेंगे बेटा. एंड जब यूरेट्रोस्कोपिक रिमूवल करना होता है वी हैव टू यूज अ डॉर्मिया बास्केट फॉर द स्टोन रिमूवल. ठीक है. नेक्स्ट, इफ द स्टोन इज प्रेजेंट इनसाइड द यूरिनरी ब्लैडर बेटा, तो जब भी स्टोन इज प्रेजेंट इन द यूरिनरी ब्लैडर वी हैव टू रिमूव द स्टोन बाय अ प्रोसीजर नोन एज सिस्टोलिथोटोमी. बट this will be a percutaneous or a suprapubic one? Sorry, perurethral or a suprapubic one? Perurethral. You will always try initially beta to go for a perurethral cystolithotomy. मतलब क्या? You will insert a scope via the patient's urethra, go into the urinary bladder and remove the stone from the bladder. तो per urethral cystolithotomy try करोगे. बट इन केस अगर बहुत बड़ा यूरिनरी ब्लैडर स्टोन है तो मुझे बताओ यूरेथ्रा से निकाल पाओगे क्या इसको? नहीं. तो इफ द स्टोन इज वेरी बिग इन साइज तो पर यूरेथ्रल इज नॉट पॉसिबल. देन यू विल गो डायरेक्टली बाय मेकिंग इंसिजन इन द suprapubic region and opening up the bladder, and that procedure is called as suprapubic cystolithotomy. That procedure will be classically known as suprapubic cystolithotomy. इन केस इफ द स्टोन इज नॉट इनसाइड द ब्लैडर बट इन द यूरेथ्रा बेटा, तो जब स्टोन यूरेथ्रा में होता है तो हमें क्या करना पड़ेगा? वी हैव टू पुश बैक द स्टोन इनटू द यूरिनरी ब्लैडर एंड वी हैव टू ट्रीट इट लाइक अ ब्लैडर स्टोन इटसेल्फ. ठीक है, तो याद रखना जब यूरेथ्रा में स्टोन होता है तो वी हैव टू पुश बैक एंड ट्रीट लाइक ब्लैडर स्टोन बेटा. Okay, push it back and treat it like a bladder stone. That is important to be remembered. Understood? Done. Next important, if I talk about beta, is a patient presents to you with complaints of abdominal mass, flank pain, and hematuria. What is the likely diagnosis? See, important is this is a case of RCC or a renal cell carcinoma, but majority cases of renal cell carcinoma do not present to you with flank pain. Majority cases are going to present to you with a painless hematuria. Clear? So याद रखना. So if I talk about the diagnosis of this patient is a case of RCC, that is a renal cell carcinoma. Now if I talk about renal cell carcinoma, it is squamous or adeno? So we know that renal cell carcinoma is again an adenocarcinoma itself, beta. ठीक है, and the most common presentation of the patient which is there बेटा, it is a painless hematuria as I've told you. तो जब भी कोई patient painless hematuria के साथ आता है बच्चे, always go for investigation, always immediately send the patient's urine microscopy. ठीक है. Next important, if they ask you that which is the most common subtype of renal cell carcinoma, the most common subtype of renal cell carcinoma answer will be a clear cell carcinoma. अगर clear cell carcinoma की बात करें तो it is commonly associated with which gene mutation? So we know beta that basically clear cell carcinoma is commonly associated with VHL gene mutation, that is a von Hippel-Lindau gene mutation beta. This has been a PYQ from NEET. याद रखना VHL gene mutation is associated with clear cell carcinoma. Now, in terms of prognosis, if I ask you beta, which is the subtype of renal cell carcinoma bache having the best prognosis? The best prognosis of renal cell carcinoma is associated with the chromophobe subtype of the chromophobe variety. Which type or which subtype definitely beta? Which subtype definitely of a renal cell carcinoma is associated with the worst prognosis? So we know that the collecting duct carcinoma beta or a Bellini duct carcinoma is associated with the worst prognosis among all. Samoma bodies will be seen in which subtype of renal cell carcinoma? Papillary. हमें पता है papillary renal carcinoma में there will be samoma bodies which will be present beta. Clear? Now in case if they say there is a renal cell carcinoma, what will be the investigation of choice? हमें पता है for all the retroperitoneal organs the best radiological investigation is always a CECT abdomen, भले वो pancreas में हो दिक्कत या फिर kidneys में हो दिक्कत. Clear है बात? तो investigation of choice as you are able to see is a CECT abdo over here, and जब CECT abdomen करोगे you are able to see a huge mass arising from the left sided kidney beta. This is a classical picture of renal cell carcinoma. अगर वो ट्रीटमेंट बोलेंगे, हमें पता है कैंसर है बेटा, तो वी हैव टू रिमूव द kidneys definitely. That is nothing else but a nephrectomy has to be done. Now nephrectomy, it depends basically which kind of nephrectomy we will do. Either we can go for a partial nephrectomy or we can go for a radical nephrectomy. अब मैं कंडीशन दे रहा हूं, तुम मुझे बताओगे whether we should go for partial or a radical nephrectomy. First condition I am talking about beta is a patient is having a cancer which is less than 4 centimeters in size. Partial nephrectomy. A patient is having a cancer beta which is more than 4 centimeters in size. Radical nephrectomy, that is total nephrectomy plus lymph node removal also. Next important, a patient is having a single kidney and that is also having a cancer. पार्शियल नेफ्रेक्टमी, एक ही किडनी है उसके पास, उसमें भी कैंसर हो गया है, तो ओनली पार्शियल नेफ्रेक्टमी। इफ पेशेंट इज हैविंग अ बायलैटरल रीनल सेल कार्सिनोमा, अगेन अ पार्शियल नेफ्रेक्टमी, क्योंकि अगर दोनों किडनीज में कैंसर है, दोनों किडनी तो निकाल नहीं सकते हो, तो ओनली गो फॉर अ पार्शियल नेफ्रेक्टमी। क्लियर? नेक्स्ट, इफ दे आस्क यू अबाउट बेटा दैट विच इज द मोस्ट कॉमन रीनल मैलिग्नेंसी इन चाइल्डहुड, हमें पता है द मोस्ट कॉमन मैलिग्नेंसी अराइजिंग फ्रॉम द किडनीज इन चाइल्डहुड इज नोन एज विल्म्स ट्यूमर, ऑल्सो कॉल्ड एज नेफ्रोब्लास्टोमा। तो नेफ्रोब्लास्टोमा इज अनदर नेम फॉर विल्म्स ट्यूमर बेसिकली। तो अगर रीनल मैलिग्नेंसी पूछा जाए बच्चों में तो आंसर इज विल्म्स ट्यूमर, बट अगर मोस्ट कॉमन abdominal मैलिग्नेंसी पूछा जाए तो आंसर विल बी, तो याद रखना मोस्ट कॉमन abdominal malignancy in children if they tend to ask you beta, or most common abdominal malignancy in childhood, answer has to be a neuroblastoma, followed by the second most common will be nephroblastoma, that is Wilms tumor. तो मोस्ट कॉमन abdominal malignancy की बात आएगी तो आंसर विल बी न्यूरोब्लास्टोमा फॉलोड बाय नेफ्रोब्लास्टोमा. Important to be remembered beta is going to be most common malignancy in childhood. Very good. ALL, that is acute lymphoblastic leukemia, is the most common malignancy of childhood beta. That is important. अब अगर मैं नेफ्रोब्लास्टोमा या विल्म्स ट्यूमर की बात करता हूं तो वी नो बेटा दैट दिस नेफ्रोब्लास्टोमा विल्म्स ट्यूमर इज एसोसिएटेड विद अ कंडीशन जहां पे द पेशेंट इज गोइंग टू हैव मैक्रोग्लोसिया, ओम्फैलोसील एंड हेमी हाइपरट्रॉफी. व्हाट इज दैट कंडीशन? तो याद रखना बेटा दैट नेफ्रोब्लास्टोमा और विल्म्स ट्यूमर विच इज देयर, इट इज कॉमनली एसोसिएटेड विद द कंडीशन जहां बेबी की हाफ बॉडी हाइपरट्रॉफिड होती है बेटा, बेबी की टंग लार्ज होती है एंड ओम्फैलोसील होता है बच्चे में, दैट इज नोन एज बेकविथ विडमैन सिंड्रोम. दिस हैज बीन अ प्रीवियस ईयर एफएमजी क्वेश्चन जहां पे दे हैव गिवन अ केस ऑफ बेकविथ विडमैन एंड आस्क्ड यू कि विच ट्यूमर विल बी एसोसिएटेड. आंसर हैज टू बी विल्म्स ट्यूमर और नेफ्रोब्लास्टोमा. क्लियर है बात? हमें पता है विल्म्स ट्यूमर के बारे में और एक इंपॉर्टेंट बात, एंड दैट इज जब हम हिस्टोपैथोलॉजिकल एग्जामिनेशन करेंगे बेटा तो क्या दिखेगा हमें? तो आई टू सी अ मिक्स्ड ट्यूमर बेटा. हिस्टोपैथ ऑफ विल्म्स ट्यूमर विल शो मी अ मिक्स्ड ट्यूमर, दैट इज एपिथेलियल एलिमेंट्स, ब्लास्टेमल एलिमेंट्स एंड mesenchymal एलिमेंट्स, तीनों टाइप के एलिमेंट्स दिखेंगे मुझे. सो इट इज अ मिक्स्ड ट्यूमर बेटा. दैट इज व्हाट इज इंपॉर्टेंट टू रिमेंबर. होपफुली क्लियर टू ऑल ऑफ यू नाउ. सो डू रिमेंबर दिस. आंसर कर लो बस, फिर चले जाओ भले ब्रेक के लिए. अरे आंसर तो कर लो. So here we are having a 40-year-old man beta who has come to the emergency room complaining of sudden onset very severe pain beta in his left loin or in his left lumbar region of 4 hours duration. That pain from the loin region is radiating to the front of the lumbar area and even to the groin and the left sided testis. He has vomited a couple of times and has an increased urinary frequency. On examination is writhing in pain, matlab he is not comfortable and cannot find a comfortable position. What is the likely diagnosis? A, B, C, D. Think and answer jaldi se. A, B, C, D. Chalo, what are we going to rule out? Option A is subphrenic abscess. No. Why? Because if it is an abscess, beta, there will be signs of infection and inflammation. Like fever should be there definitely then. ठीक है, कोई है ही नहीं. Option B says pyonephrosis. Pyonephrosis is again due to infection, especially renal TB, beta. So long history, again fever-like features. Nothing is mentioned over here. We are left with two conditions. One is nephrolithiasis and second is ureteric calculi. Both are stones, beta. तो अब हमें पता है स्टोन्स में इंक्रीज यूरिनरी फ्रीक्वेंसी एंड पेन, दीज आर द टू मेन सिम्टम्स जो दिया हुआ है यहाँ पे. तो बताओ मुझे कि व्हाट विल बी द सी और डी रीजन. If the pain is radiating from the lumbar or the loin region, it has to be inside the ureter then. क्योंकि हमें पता है जब nephrolithiasis होगा, that is only stone inside the kidneys, there will be a fixed lumbar pain. अगर वो ureter में होता है तभी pain radiate करता है, तो answer has to be option D, that is a ureteric stone or a ureteric calculi. And last year recent NEET PG का question था, बताओ. We have a 30-year-old male beta who was investigated for infertility. Semen analysis reveals there is oligospermia, that is a decreased sperm count. Biopsy image of the patient has been given below. What is the most probable diagnosis of the patient? Bolo. आंसर would be option D, that is a testicular atrophy. मुझे बताओ एक नॉर्मल चीज है ये, what are these tubules inside the testis called as? Seminiferous tubules. So this is a cut section or a histopath of testis जहां पे seminiferous tubules are seen. Inside the seminiferous tubules, बेटा, the amount of cells that you are able to see are more or less, हैं? ज्यादा सेल्स होते तो ज्यादा ब्लूइश डॉट न्यूक्लियस के दिखते हैं मुझे, मुझे नहीं दिख रहे, मतलब द नंबर ऑफ सेल्स आर गोइंग टू बी लेस. एंड अगर सेल्स ही कम है तो काहे का ट्यूमर? ट्यूमर में सेल्स कम होते ज्यादा होते हैं? ज्यादा होंगे ना, तो पूरा नीला नीला दिखना चाहिए था, इतने सारे डॉट्स दिखने चाहिए थे मुझे, राइट? तो दैट दिस इज द इजीएस्ट वे आई एम टेलिंग यू हाउ टू डायग्नोज अ कैंसर. तो प्लीज रिमेंबर, सेमाइनोमा या नॉन सेमाइनोमेटस टेस्टिकुलर ट्यूमर दोनों होता तो ऑब्वियसली बेटा यू शुड हैव बीन एबल टू सी मल्टीपल डॉट्स बेसिकली इनसाइड द हिस्टोपैथ बेटा. बट इट इज नॉट सीन, मतलब द नंबर ऑफ सेल्स इज रादर लेस. एंड अगर सेल्स कम है तो मैलिग्नेंसी या ट्यूमर हो ही नहीं सकता. देन वी आर लेफ्ट विद ऑर्काइटिस और टेस्टिकुलर एट्रोफी. अब ऑर्काइटिस होता तो देयर शुड हैव बीन हिस्ट्री ऑफ मम्स, देयर शुड हैव बीन समथिंग रिलेटेड टू इन्फेक्शन, फीवर होना चाहिए था, पेन स्वेलिंग रेडनेस होना चाहिए था, कुछ नहीं दिया हुआ. So the only option that we have left is nothing else but testicular atrophy. Atrophy mein there is decrease in the number and size of cells which is seen over here, and due to that the patient is having a decreased sperm count also that is given, that is oligospermia. So this is the recent NEET PG question. Yaad rakhna, here again nobody teaches testicular atrophy, even in NEET or INA set, nobody teaches testicular atrophy. This was a question that you had to diagnose just by ruling out the options. तो कभी कभार तुम बहुत बार बोलते हो सर ये टॉपिक में नहीं है, फिर वो टॉपिक तुम टेक्स्ट बुक में ढूंढने चले जाते हो. दैट इज नॉट डन. तुम्हें बाकी चीजें पता होनी चाहिए, तुम बाकी चीजें लॉजिकली रूल आउट करोगे, ये कभी कभार होता है. तो हर एक क्वेश्चन एग्जैक्टली हर एक टॉपिक पढ़ाया जाएगा ये जरूरी नहीं होता है, स्पेशली सर्जरी मेडिसिन ये दो सब्जेक्ट्स में. ठीक है? इवन फॉर ऑफ्था एंड ऑफ्था फॉर दैट मैटर एज वेल, बहुत सारी चीजें होंगी जो शायद नहीं पढ़ाई गई या बहुत नोट से बाहर से आएगी. तो वो तुम्हें एक्सपेक्ट नहीं कर रहे कि तुम डायरेक्ट आंसर पता हो, वो तुम्हें ये एक्सपेक्ट कर रहे कि तुम बाकी चीजें रूल आउट कर दो जो तुम्हें पता है. दैट इज व्हाट इज डन. क्लियर? चलो, गो फॉर अ ब्रेक.